Welcome back to NCLEX. This lecture is going to be on cardiovascular disorders. Let us begin. In order to understand some of the basic concepts relating to the heart, we need to understand a couple of equations. Now, keep in mind, I didn't say memorize a couple of equations. I said understand a couple of equations. Let's start first by talking about cardiac output. Cardiac output, which is often abbreviated CO, equals stroke volume times heart rate. Cardiac output equals stroke volume times heart rate. Cardiac output equals stroke volume times heart rate. So, the output of your heart is measured by how much volume is coming out per stroke, so how much blood is being ejected by the heart, and then how many times that heart is beating, okay? So this is your cardiac output. And it's going to come in handy, and I'm going to explain it to you in a second. For now, keep that equation in mind. Blood pressure is cardiac output times total peripheral resistance. So blood pressure is cardiac output times total peripheral resistance. Let's go over that one more time. Blood pressure is cardiac output times TPR, or total peripheral resistance. Why do these equations matter to you as a nurse? Because if you understand these equations, you're going to understand why certain medications are given and what can be done to prevent certain conditions. So let's think about it. Cardiac output, we said, was stroke volume and heart rate, right? Well, when is your stroke volume going to drop? Stroke volume is going to drop when volume in your body goes down. When does volume in your body go down? Well, if you don't drink enough water, if you pee too much, right, you'll become dehydrated. If you become dehydrated, your volume is going to go down, and as a result, your stroke volume is going to go down. Everybody follow? So how's your body going to compensate? Well, it wants to keep the cardiac output normal, right? The normal values are listed for you as 4 to 8. Okay, 4 to 8 liters is the normal value for this. It's going to be usually around 5. So let's say you're dehydrated because you haven't drank enough water or because you've been peeing too much or urine output is too high. How is your body going to maintain that cardiac output? It's going to do it by trying to raise heart rate, okay? Because stroke volume has gone down, so now heart rate must go up to keep that cardiac output maintained and regular, right? So we talk about this when we get to shock. We talk about how volume drops and you become tachycardic. Now you should understand why that happens. So let's go over some hemodynamic measurements, some normal values, okay? And I want to explain to you hypertension as it relates to those equations and then medications we use to treat them. Your cardiac index is something you should know. That's going to be around 2.5 to 4 liters a minute, okay? That's your cardiac index. We talked about cardiac output already. We said how cardiac output is calculated by multiplying your stroke volume times your heart rate, okay? And those two values, when multiplied, should lead to a number between 4 and 8 liters a minute. Normally going to be around that 5 liter a minute mark, okay? So between 4 and 8. And remember, when stroke volume goes down, heart rate may go up, right, to compensate. Central venous pressure, okay, this is another live value you should know. It's going to be 2 to 6 millimeters of mercury. So this is going to be 2 to 6. So we have cardiac index, which we said was 2.5 to 4. Cardiac output, which is very important, keep that in mind. That's going to be between 4 and 8, normally around 5, and then central venous pressure around 2 to 6. Your stroke index and stroke volume, people can confuse the two. Don't do that. Remember, stroke volume is used for cardiac output, not stroke index. You guys won't be doing a lot of calculations, but it's important to understand and recognize these values. Stroke index is going to be between 25 to 45, okay, 25 to 45, and stroke volume between 50 and 100. So you take that stroke volume of 50 to 100 and you multiply it by an average heart rate, and you should end up between 4 and 8 liters a minute. Your systemic vascular resistance, that's your systemic resistance, okay, that's going to be between 800 and 1200. 800 and 1200. The next one's actually quite important. It's your mean arterial pressure, okay? And this is important because this is going to tell you a lot about perfusion, okay? And if your mean arterial pressure is not at least 60, that means your organs aren't being perfused properly, okay? And we're going to talk about perfusion later in cardio as well as in other lectures. So your mean arterial pressure must be at least 60 for adequate organ perfusion. That means enough blood flow and oxygenation to that tissue or that organ, okay? Normal range for mean arterial pressure is going to be between 70 and 100, but 60 is the minimum for adequate perfusion. Your pulmonary capillary wedge pressure, your PCWP, okay, pulmonary capillary wedge pressure, that is a measurement that's obtained by doing this it's like a balloon inflation procedure that they do. That's going to really measure what's going on in your right atrium. That's your PCWP, pulmonary capillary wedge pressure, and that normal value is between 4 and 12. I know that it seems like there's a lot of numbers here, okay, but really, as long as you can recognize them, you'll be okay. Just make sure you know at least your stroke volume average, which is 50 to 100, cardiac output between 4 and 8, and then your mean arterial pressure, that 60 is really a minimum that you need, and 70 to 100 is normal. So now let's talk about hypertension. And so you should now be able to tell me the blood pressure equation. So I'll give you a second to think about it. You should have come up with blood pressure equals cardiac output times TPR, total peripheral resistance, and therefore you know that blood pressure therefore equals stroke volume times heart rate, which is cardiac output, multiplied by TPR. So blood pressure equals stroke volume times heart rate times TPR. Well, we're going to talk in a second about beta blockers, right? But let's really figure out hypertension first, these normal values, right? So hypertension's elevation in blood pressure, okay, is going to be a systolic pressure of greater than 140 and a diastolic greater than 90. So systolic 140 and diastolic 90. So if it's greater than 140 on top or 90 on the bottom for at least 2 readings, that's positive for hypertension. Now, so signs and symptoms, one is simple because you can actually measure it. That's going to be your elevated blood pressure. And you can also have a headache. Okay, this is due to a decreased supply to your brain. You can also have visual disturbances, okay, because you're not getting this this proper circulation. But also keep in mind that you're always going to have visual disturbances as a problem when you mess with your vessels, okay. And so you'll see that in diabetes, when you mess with vessels, you'll have visual problems. And that's not due to the diabetes per se. It's really due to the hypertension kind of associated with that diabetes, as well as palpitations because your blood pressure is up, and we saw how that equation relates to your heart, right? And so signs and symptoms for hypertension, they're not too complicated, okay? What predisposes somebody to hypertension? Well, there's 2 kinds of factors. There are factors that really can't be changed, right? So factors that can't be changed are like your age. You can't change your age, you can't change your ethnicity. So men who are above, men younger than 65 and women older than 65 have a higher risk, okay? So men under the age of 65 and women over the age of 65. And so why women over the age of 65 and men younger? Well, women will talk about an endocrine and maternity, but I'll touch on it briefly here. It's due to this estrogen effect, okay, because estrogen serves as a vasodilator and muscle relaxant, okay? And so when that estrogen starts to wear off, okay, that vasodilation, that muscle relaxant property goes away. And when you lose the relaxation, your blood pressure can go up, okay? So we'll talk more about that in endocrine and maternity, but I'm just going to touch on it here. Another non-modifiable risk, or another risk factor that you can't change, is if you're African American, right? Because you can't just wake up one morning and say, hey, I want to be white. It's not going to work. Okay? Michael Jackson always comes to mind. He didn't decide to turn white. He had an autoimmune disease called vitiligo, okay? Where you start turning white, you lose pigmentation. It starts in your arms and works your way up, which is why you always wear a white glove, right? Modifiable risk factors are risk factors that you can actually change. You can do something about to prevent getting hypertension. And so you want to educate your patients on how to decrease these risk factors. So stress is one. And that's really due to a lot of stress hormones, right? Because your body reacts really negatively, and stress can be really bad for you. And there's so many studies being done showing that it can affect everything from mood to literally every organ system in your body, and how detrimental it can be to your health. A high cholesterol diet, okay? A high sodium diet, as we know, having too much salt. That's why nowadays, people try to cut back on it. A sedentary lifestyle, if you're not working out enough, you're kind of stationary, you're not active. That's another risk factor. Smoking, okay? Smoking is a risk factor for hypertension because it does tighten your vessels, right? Alcohol, we all know alcohol is a risk factor. Being overweight. One that people overlook sometimes is oral contraceptives can also be a predisposing risk factor, okay, to hypertension. And having a type A personality like I do, always being on the go, always wanting to get things done, always being stressed out, right? That's a predisposing risk factor to hypertension. As well as comorbidities, and this is kind of like, anything else that might lead to hypertension, such as diabetes mellitus. That's a big one, so know that. So we're going to talk about antihypertensive medications, and I'm going to kind of give you a connection back to the equations we learned about earlier and explain to you what heat stroke is so you can really figure out why these equations are important. Okay, because it's always good to know normal and normal physiology, because if you know normal, then abnormal will slap you in the face. So a lot of these hypertensive meds, well, what's the goal? What are they trying to do? Well, hypertension is when your vessels are too tight, right? So chances are that these medications are in one way or the other going to relax your vessels, right? They're going to relax your vessels. So what's going to happen? Normally speaking, the side effect of the drug, okay, is going to be the opposite of what you're trying to treat. So they're too hypertensive, so you loosen their vessels. Maybe you loosen them up too much, and now they're hypotensive. So treating hypertension, side effect can be hypotension, right? Because you've loosened them up too much. Well, they can become dizzy because now what happens is you dilate those vessels so much that blood flow, okay, is not flowing the way it should be, and so they're losing some kind of balance. Let's keep it that way, okay? They get dizzy, they become lightheaded. And because you're dilating vessels, you might do it too much. They might have orthostatic hypotension. Because in the bottom of your legs, what you really need to happen is you need those vessels to be tight to put that blood back into circulation. This is why they tell you, stationary people who don't move around a lot, they don't stress enough, they don't stretch enough while they're flying, they don't constrict those vessels at the bottom of their legs, and so that blood doesn't flow enough, and they can lead to pulmonary embolisms because they get a DVT or something, right? So orthostatic hypotension can be a side effect so orthostatic hypertension is a side effect of antihypertensive medications. Here's the goal again, right? Cause vasodilation, lower your blood pressure, decrease that heart rate, right? Take the load off your heart, make your heart work less. Let your vessels relax a little bit. Well, anytime you're going to give an antihypertensive medication, you're going to have to do certain things, right? You're going to have to check their vital signs. Make sure they're not hypotensive. Make sure their heart rate isn't dropping too much, right? Because these medications are going to do that. So you're going to hold the blood pressure medications if they're too hypotensive. And so remember, hypertension was above 140/90, right? And too low or too hypotensive is 100/60. So if you're giving these blood pressure medications and they're hypotensive now, 100/60 or less, you're going to have to hold those meds, okay, and call a doctor. Educate your patient on non-pharmaceutical methods of reducing blood pressure. And this is very important. We're going to talk about that in a second because there's one that most people don't know about. Diet. We talked about don't have too much salt in your diet because that's a predisposing risk factor, a modifiable one that we just mentioned on the previous slide. You want to make sure that your patients are taking adequate vitamins, especially your B vitamins, because this will help decrease the signs and symptoms. Okay, and the signs and symptoms such as tingling and pins and needles, because a lot of these B vitamins are important for myelination of your nerves, okay? So if you don't have these B vitamins and your nerves aren't, let's say, adequately insulated, they can't adequately convey or transmit a signal, okay? Then you're going to feel like you don't have a signal. You're going to have like a numbness or a tingling or paresthesis, pins and needles feeling, okay? Now, we said hypertension is too much or elevated blood pressure. We said blood pressure is cardiac output times total peripheral resistance. And we said cardiac output was stroke volume times heart rate. So we have blood pressure equals cardiac output times TPR, and cardiac output is heart rate times stroke volume. So now, what is something that everybody can do to lower their blood pressure? They want to keep their stroke volume up, right? They want to keep their volume adequate. So let's see what happens. If your volume goes down, here's your equation, okay? Blood pressure equals heart rate times stroke volume times total peripheral resistance. So you've got three factors here. If your stroke volume goes down, your body's going to react by increasing your resistance. Well, if you increase your resistance, your blood pressure is going to go up. Understand? So it's very important now to drink water. God was telling us something when He gave us the earth and said, hey, most of this is water. You know why? Because it's important for you. I want you to drink it, God said. Okay? Now, if you don't drink enough water, what's going to happen? Your volume's going to drop. If your volume drops, your stroke volume is going to drop. If your stroke volume drops, your total peripheral resistance is going to go up. So if you drink enough water, your patients drink enough water from an early onset, okay, you can actually use that to prevent the risk of getting hypertensive. Okay? So now, we're going to go back and talk about this again when we talk about beta blockers. But for now, keep this in mind. A healthy lifestyle includes drinking a lot of water for this reason. Okay? Got to keep that volume adequate so your body doesn't react by saying, hey, look, I don't have enough volume, so there's not enough blood getting to where it needs to go, so let me tighten up my vessels to help it get there. To help me preserve what little I do have. Drink enough water so your vessels don't try to save anything by tightening those vessels and raising your blood pressure. Now, once you already become hypertensive, drinking a lot of water may not necessarily help you because it's too late. It's good to have a healthy lifestyle, okay? So you can stop it from becoming a risk factor before it gets to that point. Thiazide diuretics don't have an immediate effect on your blood pressure, okay? But what they do is they help you get rid of sodium, which is going to help raise, which is going to normally be responsible for raising your blood pressure. So they help get rid of that sodium, okay? And so anytime you're giving a diuretic, because what's going to happen is they're going to have diuresis, right? They're going to start peeing, right? If they start peeing, what's going to happen? They're going to pee out things that they might need. So you want to make sure that you're seeing that they're not peeing out too much. So you got to monitor their electrolytes, make sure they're not wasting all their electrolytes. Monitor their glucose, make sure they're not losing all their glucose. Monitor their calcium. Okay, then you got to monitor their kidney function too, because these drugs affect the kidney. So you're going to monitor their BUN and creatinine levels, and also the uric acid levels. Okay, loop diuretics. These are like Lasix or furosemide, and what these do, okay, is these will really cause a rapid decrease in fluid. Okay, so these are going to help get rid of fluid really, really quickly. Okay, and so what will happen now is you're going to affect your blood pressure, because this right here is going to inhibit sodium reuptake. Okay, don't get too hung up on these details. Okay, they're going to inhibit sodium uptake, and these loop diuretics are very, very potent. I guess we can say potent's not the right word. They're very, very effective, and they lead to rapid diuresis. So you'll lose these loop diuretics a lot in the ER. You'll see them use like furosemide or Lasix when somebody walks in. Okay, now loop diuretics like furosemide I already told you, thiazide diuretics. And then we have osmotic diuretics, and these help you get rid of kind of all your water, like mannitol, I call it, right? Or osmetol. Now, anytime you use those diuretics, none of them are potassium-sparing diuretics, right? And if you remember back from the electrolyte lecture, I told you that anytime you mess with potassium, you mess with your QT interval, okay? All these diuretics, they're not potassium-sparing. We haven't talked about those yet, so you should definitely check potassium levels. Anytime you're peeing anything, I told you already, right? Check your electrolytes, see if they're not wasting what they need. Check their glucose, check their creatinine and BUN to see what how their kidney function is. Make sure that that diuresis isn't affecting their kidney too much, that medication isn't too hard on their nephron, right? Potassium-sparing diuretics now, these are diuretics that help promote sodium and water excretion. So you're still going to get rid of your sodium, but you're going to hold on to that potassium, okay? And they sometimes use this with other diuretics. The contraindication for a potassium-sparing diuretic is going to be somebody who has really bad kidney disease, okay, or really bad hepatic disease, and somebody has too much potassium already. Because think about it. If they already have too much potassium, do you want to spare their potassium even more and give them more, or do you want to let them get rid of it? You want to let them get rid of it, right? What these adrenergic blockers do is they decrease your vasoconstriction, and because you are decreasing vasoconstriction, you are by default promoting vasodilation, right? And vasodilation is one of the goals of hypertension, right? Treating hypertension. So this will, reduce the effects of norepinephrine, which is responsible for that sympathetic vasoconstriction, which we mentioned in the ANS lecture. So common ones that we use are like these alpha blockers, like end in zosin, like doxazocin, terazosin, drugs like that end in zosin. And once again, our side effects, well, these should make sense to you, right? So what's going to happen, okay, if you lower your blood pressure too much? If these medications go a little too far, well, they can have hypotension, orthostatic hypotension. And because now they're hypotensive, your body can react by becoming tachycardic, by raising the heart rate, right? Going back to that equation. So side effects so far, we have hypotension, orthostatic hypotension, reflex tachycardia, which means that your heart rate is going up as a reflex to what's happening. Sodium and water retention now, because you're hypotensive, so your body's saying, okay, wait, let me save some sodium, get my blood pressure back up. Nausea, that's, you always have nausea with many of these drugs, okay? Drowsiness and nasal congestion. Why is that? Well, if you look at all these nasal decongestants on the market, what they're doing is they're tightening your vessels, and this is opening them. So this can lead to nasal congestion, the opposite of decongestion. Okay? Edema and weight gain, because now you're vasodilating so much, you're not having enough circulation, so that thing can just pool, right? And you can get edema, and you can gain weight because you're holding on to that water. You have a little retention going on, right? That's another one of your side effects. On to water, I'm going to gain weight. And remember, a lot of your weight comes from water. So what are you going to do if you're a nurse and somebody's on an alpha blocker? Well, you're going to have to monitor their vital signs, right? Because we said hypotension is a risk factor. You've got to monitor their heart rate and their blood pressure. And you got to check for fluid overload. Are they pooling too much fluid? Are they too hypotensive? Is that blood not circulating? Are they holding too much water? Do they have edema as a result? Are they not hypervolemic as a result? So another one we said was orthostatic hypotension, right? If you vasodilate too much, they become hypotensive. So how can you prevent that? Well, make them move around. Because if their blood vessels aren't tight enough to put the blood back into circulation, you can move them around to help accomplish that goal instead, right? Change their positioning. And another thing you can do, okay, you want to do, is decrease their salt intake and over-the-counter medications, because there's some reactions associated with it. So you always want to be safe and avoid those. Now, another thing about these drugs you want to keep in mind is they can be associated with what we call rebound hypertension. What that means is if you've vasodilated, but if you take that drug away too quickly or you stop it abruptly, guess what's going to happen? Boom, it's going to go right back down. That vessel's going to tighten right back up and you get rebound hypertension. So don't stop these drugs immediately. You got to kind of wean them off of it. And because these drugs are mostly fat soluble, and we talked about how fat soluble drugs go to your liver, you're going to have to monitor liver function tests, okay? Sometimes doctors will prescribe beta blockers, and they all end in LOL. So these beta blockers end in LOL, and these beta receptors that are located all over your body, okay, do various things. The one in your heart, when stimulated, like we said, increases your heart rate. So if beta receptors normally increase heart rate, but you now are blocking it, can you increase your heart rate? No, you can't. So let's talk about this. Let's say somebody is on a beta blocker, and they're working out, they're running, they're exercising, and they don't drink enough water. Guess what happens? The stroke volume goes down, resistance goes up, but as per our equation, heart rate can't be raised, right? So you have a decrease in volume because you're sweating or you're not drinking enough water when you're on a beta blocker, right? Your resistance is going up, the blood pressure is trying to go up, your body's going to try to compensate, but it can't raise your heart rate because you have a beta blocker. And so you're blocking that receptor responsible for raising your heart rate. You know what happens then? You get heat stroke. That's what heat stroke is, okay? So just tying it back to that equation we talked about earlier. ACE inhibitors and ARBs, so this is a angiotensin converting enzyme inhibitor. Angiotensin tenses your angios, makes them tighter, makes your blood pressure go up. So if I prevent it from converting into angiotensin, I'm going to prevent having angiotensin. I'm going to prevent the tension of my vessels, thereby relaxing them and lowering blood pressures, right? And they use ACE inhibitors because they work on the kidney area, right? Because of the ACE inhibitors, that's the mechanism of action, the site of action at least. So you'll see a lot of people with kidney disease on ACE inhibitors. All these ACE inhibitors end in pril, lisinopril, pril, captopril, right? And these work, like I said, through the RAS system, the renin-angiotensin system. And the side effects of this are cough, tachycardia, nausea, and vomiting. And let's kind of talk about this. Angiotensin, because of the effect it has on this thing called bradykinin, which I won't get into too much detail, okay, can lead to an increase in, lead to a side effect of cough and tachycardia. Now, the cough that they may have, if they're on a pril, okay, is going to be a dry cough. And it's going to be a pretty common complaint with people who are on these types of medications. All right, so you're going to have to definitely let your physician know, the prescribing physician know, because cough is a side effect of these ACE inhibitors. As also is angioedema. So what happens is they get this little edema in their angios, kind of like a facial type of edema even. And so you might have to switch them to another drug if you notice that. Okay, so if they start coughing too much on a pril, call the doctor and take a look and be on the lookout for that. ACE inhibitors want to be given on an empty stomach or 2 to 3 hours after a meal. Okay, the environment they need is going to be one that is going to be conducive to absorption. An empty stomach is, or after a meal, when that meal is 2 to 3 hours after a meal, after it's already passed through that area, is when you want to give that med. ARBs are similar to ACE inhibitors, okay? But what they do is they are angiotensin 2 receptor blockers. So instead of you not making angiotensin, you're just blocking where it's going to work. And so what that does is it also prevents angiotensin from tensing your angios. And so that'll lead to a increase in vasodilation by default. And so this you want to avoid with potassium-sparing diuretics and potassium supplements. And these ARBs and ACE inhibitors are actually now known and proven to decrease mortality in people who have heart failure. So you'll see these drugs given quite a bit. Remember, the body wants to protect the kidneys and the heart and then the brain. It wants to protect the brain, the heart, and the kidneys. And it sacrifices bottom up. Most people die of heart failure. So you'll see a lot of people on these drugs to prevent that risk of morbidity or lower that morbidity risk. So coronary artery disease, that's going to really speed up the process of somebody getting hypertension. And this is why, okay? There's 2 types, arteriosclerosis. And sclerosis just means stiffening and narrowing. It's sclerosing. It's just becoming harder. It's becoming stiffer. So think about just like a balloon or a straw, right? This is your blood vessel right here. And now it becomes narrower or it becomes stiffer. Well, your blood pressure is going to go up because if you take something like a bottle of water or like a balloon, balloon's probably the best example. Take a balloon, fill it with water, squeeze it. What happens? Pressure goes up. Water starts flowing faster, right? That's what's happening here. Arteriosclerosis just means you're tightening up and you're stiffening. And because you're tightening up and stiffening, by definition of what's occurring here, it's going to lead to hypertension eventually, okay? Atherosclerosis is a deposition of fat. So that's also providing an impediment, right? So instead of it becoming stiffer or tightening, it's in effect acting like it's tighter because something's getting in the way. Plaque is building up. Something's building up and causing a higher blood pressure. So this can also lead to narrowing and decreased diameter, eventually leading to hypertension. So signs and symptoms. Well, intermittent claudication. People always kind of get confused. And all this is due to decreased blood supply going somewhere, all right? And so what happens is you have this imbalance between how much oxygen you need and how much oxygen is getting there. And because it's a supply and demand issue, okay, and oxygen demand goes down when you're resting, this intermittent claudication or pain, okay, will stop when somebody rests because it's intermittent claudication. Once again, due to inadequate balance between the supply of oxygen available and the demand of oxygen needed. And how can you lower your demand of oxygen? How can you lower the demand of oxygen? Rest. And so when you rest, these people will say the pain went away. They can also become forgetful because they're hypoxic, okay, so they don't have enough oxygenation, so it leads to little memory issues and they forget things. If you have less blood going to where it needs to go, that area is not going to function as well, right? So if you have decreased blood supply going to the follicles of your hair, okay, you can start losing your hair, all right? As a result of having less blood supply, you can have decreased pulse, which is going to be related to that decreased blood supply. So less blood going through, you'll feel a diminished or decreased pulse, right? As well as hypercholesterolemia is another sign or symptom of coronary artery disease. So how are you going to diagnose, or how is coronary artery disease normally diagnosed? Well, it's done with the ECG, okay, or what they do is a cardiac cath, or some people call that an angiogram. They take the patient into the cath lab, they lay them down, they stick a little, let's call it a little camera on a wire, okay? They stick it in there, take it all the way up through the leg into the heart, and do some exploring and put that wire through and with a little camera on it, see where the blockage is. And they can, based on that blockage, they can either use a balloon or a stent, which we call the percutaneous, right, method, and enter a stent in there to kind of open up that vessel so it's not tight anymore, open up that vessel because there's too much plaque, and let that blood flow become adequate. Because remember, ischemia is not good. If they don't get enough blood, they can have a heart attack. We'll talk about that with MI in just a second. So, in addition to the ECG and the cardiac cath to see if there's any blockage visually, right, and that's what we normally a cardiac, an interventional cardiologist will do that. You can also check blood lipid levels to see how much cholesterol they have, right? And remember, LDL is bad cholesterol, HDL is good cholesterol. High, remember the people that are high, they feel good, okay? So high HDL stands for high density lipoprotein. Good cholesterol, good feeling when you're high, okay? HDL is good, LDL is bad. All right, medications that are used. Nitrates, what do nitrates do? Well, back to the ANS lecture, we talked about how, the parasympathetic system works via cyclic GMP. That's what nitrates do. They increase cyclic GMP, that parasympathetic effect, that dilation of your vessels. Okay? So these nitrates dilate your coronary arteries. So when somebody walks into your office or somebody has symptoms of coronary artery disease, the problem in essence is narrowing of the vessel, whether it's becoming tight or whether things are blocking it. So what you want to do is give it more room, more diameter, and you want to dilate that vessel, and that can be accomplished by nitrates. Be very careful if your patient is also taking like a Viagra or something, okay? Because those things like sildenafil or vardenafil, right, what do? Fill the corpus cavernosum with blood. And so in order to do that, they have to vasodilate. Well, if you have another vasodilation drug like a nitrate on top of a sildenafil or vardenafil, their blood pressure is going to drop and they could actually die because you're dilating with one drug and then dilating with another drug. And we talked about that in the previous lecture. They may also give calcium channel blockers, okay? And what calcium channel blockers will do is they'll dilate the arteries and prevent like a vasospasm from occurring, okay? And so these calcium channel blockers will inhibit the ability of that vessel to tighten, and so they'll dilate them and provide more room for that blood to flow through. And we also talked about beta blockers earlier, and beta blockers will reduce blood pressure in people who are hypertensive, okay? So nursing interventions, what are you going to do to a patient with CAD? Well, this is really going to boil down to lifestyle changes. They're going to have to change the way they've been living because their lifestyle hasn't been conducive to good health, hasn't been conducive to having a long, healthy life. So what do you want to tell them to do? Well, low sodium, low cholesterol, and add fiber. Fiber is very important because fiber just in general helps with absorption, okay? That's why vegetables are so good for you. They all have fiber in them. Low sodium, low cholesterol, high fiber diet. Exercise 2 to 3 times a week at least, 30 minutes at a time. You don't have to go in and try to be a bodybuilder, but work out, get your blood flow going, relax those vessels, get rid of some of your stress. Stop smoking, or at least minimize smoking, okay? Or else, because smoking is a risk factor. Avoid alcohol because alcohol is going to contribute to coronary artery disease, as well as, wear loose garments, okay? If you're just walking around wearing skinny jeans all the time, okay? Wearing tight belts to keep your pants on, it's going to tighten those vessels, and it can also lead to high blood pressure because it's actually tightening the vessels for you, okay? Antilipemic medications or antilipemic medications are also used, and remember, lip means fat, so these are like anti-fat or anti-cholesterol medications. So what these drugs will do will help prevent the absorption of cholesterol and fat. So if they're eating it, you're just going to block the absorption in your body, so they just poop it right back out. So these are like statins or fibrates and bile acid resins, which we talked about earlier. Side effects of these drugs, because they are messing with absorption, okay, and that's, like a GI problem. If you're not absorbing that food that you're having, it's got to come out, right? So it can come out of your top end, you can have nausea or vomiting. And because these drugs are dealing with fat, they are fat soluble, and fat soluble drugs go where? To the liver. So as a nurse, you're going to monitor their liver function tests, right? And you want to give it with meals because fat soluble drugs are going to absorb better in a basic environment. So we want to give it with that meal to have a basic environment, and it's going to absorb better in their body, okay? You're going to want to make sure that you make sure this patient is safe, because remember, fat-soluble drugs can cross into membranes, right? They can cross into your eye, cause eye problems, cause into your muscle, cause muscle problems, right? So watch the visual disturbances, see if their vision is changing. Recommend an annual eye exam to make sure that they're in good eye health, okay? Because they're fat-soluble, because they're messing with absorption, okay, and because fat-soluble vitamins are important to your body, okay, they may need supplementation of these vitamins, because as a result of decreasing absorption of fat things, you have also unintentionally decreased the ability of your body to absorb fat-soluble vitamins. Remember, fat-soluble vitamins are ADEK, A-D-E-K, A-D-E-K, and B12, A-D-E-K, and all the B vitamins. So B12 is absorbed, A-D-E-K are fat-soluble vitamins, but B12, okay, even though it's water-soluble, acts fat-soluble. So A-D-E-K and B12. And remember, we talked about B12 being important for neurofunction. If you don't have enough B12, you'll have pins and needles feelings. If as a nurse, somebody on a antilipemic medication like this says, hey, I feel some tingling, I feel pins and needles, if something feels weird, maybe a sign to supplement their vitamins. Maybe it's not being absorbed properly because you're blocking absorption. They must have hydrochloric acid in their body to absorb vitamin B12, okay? So maybe that's a problem if they complain of those symptoms. Remember, the diet we want them to be on is a low-fat, low-cholesterol, high-fiber diet, okay? So, and high in vitamins, high in these fat-soluble vitamins, A, D, E, K, and vitamin B12, and recommend iron supplements to them also. So we talked about these coronary artery disease and those medications. Let's move now into congestive heart failure. So CHF can be right or left-sided, depending on what the etiology or what the cause is. So what can cause heart failure? Well, heart failure, in simple terms, is when the heart fails to work like it normally would, right? So what's going to make something that normally works, or works normally, stop working normally? Well, it's going to be one of 3 things, generally speaking. One is that the heart needs more nutrients, okay, in order to work, which means the metabolic demands of the heart have increased. Number 2, the heart has to work harder, okay, because there's either a backflow of blood maybe, which means the heart has to work harder to try to get that backflow and get it circulating again. Or number 3, maybe the vessels are too tight and it's harder for that heart to pump against that resistance because it's harder to get blood into these vessels if they're tighter, right? So what are the specific things that can cause it? Well, if somebody has a heart attack, right, that means some of the tissue in the heart is probably necrosed, which means it's not going to work properly, which means now the heart has to work harder to compensate for that. So that can lead to heart failure. A valvular defect, which means a valve isn't functioning properly, which means blood can't get through that valve properly, and maybe now as a result of it, think about it kind of like a roadblock, right? Instead of being able to get through, now has a little bit of a roadblock, it's not working right, so the blood is backing up, right? That could cause heart failure because it's going to make the heart work harder to try to get that blood through there. Hypertension, which we already said, makes it harder for that heart to pump blood into those vessels. That can make the heart work harder and lead to heart failure. Atherosclerosis and arteriosclerosis, right? Narrowing of the arteries or deposition of plaques or fats in the arteries can make the heart work harder. Anemia. Anemia can make the heart work harder because your body thinks there's not enough blood or not enough good blood, let's leave it that way, getting to where it needs to go. So the heart feels like it has to compensate. And that can increase the heart workload and lead to heart failure because it's making the heart work harder. And it's especially going to happen when there's concomitant polycythemia, okay, which will increase blood volume, but it's not really like good blood, let's leave it that way, or there's too much blood, okay, and it has to work harder to get that sheer volume of blood to where it needs to go, and that puts stress on the heart, right? Hyperparathyroidism, what that does is that makes the heart work harder because it increases what the heart needs to work, okay? So hyperparathyroidism makes it to where the heart needs more metabolic demand. It has a higher metabolic demand. It needs more nutrients or oxygen to work, and therefore increases the work of the heart, right? And that can lead to heart failure if you don't have adequate metabolism or if you don't adequately meet the demands that the heart needs. Any circulatory overload, okay? And so what this will do is anytime there's too much fluid or too much, there's a transfusion or, you know, there's just too much fluid in there, the volume has gone up. And now your heart has to work harder because there's just more stuff that has to be pumped around, okay? Left-sided heart failure. How can you tell it's left-sided? Because left-sided heart failure, L for left and L for lung, okay? So it's going to be pulmonary or lung-related signs and symptoms such as shortness of breath, dyspnea, fatigue, crackles in the lung. Pink sputum, which says that, you know, these small vessels now in the heart, right, have ruptured, right, due to this, and then led to congestion, right? So these small ruptures led to congestion. And now when you're coughing up, it's like a pinkish sputum, and that pink is just blood. Cyanosis, because that lung, that left, L for lung, lung side effects, right, or signs and symptoms, sorry, are related to breathing, and oxygenation. So now you're not having adequate oxygenation, leading to cyanosis, right? And orthopnea, that's another one, right? And then paroxysmal nocturnal dyspnea, that just means you're short of breath at night. So if you see lung-related symptoms, think L for lung, L for left, and that's left-sided heart failure that presents with lung-related symptoms. Left-sided heart failure occurs first, okay, because it's the pumping action of the heart. So when that pump isn't working effectively, that blood is going to backflow into the right side of the heart, eventually leading to right-sided heart failure. So left-sided heart failure can lead to right-sided heart failure. Right-sided heart failure is sometimes called cor pulmonale. How do you remember that? Well, people get confused. They see pulmonale and they're like, oh, that's pulmonary, that's left-sided. No, look, left-sided heart failure, L for left, L for lung. Got it? Right-sided, R, core has an R in it. That's why I keep them straight, okay? So pulmonale is lung, so right-sided heart failure is also called cor pulmonale, which left-sided can lead to right-sided. And so cor pulmonale and right-sided heart failure are really failure of both sides of the heart to work, right? So these are you get some systemic signs and symptoms. Okay, so what are you going to see? You're going to see hepatomegaly. What is that? Megaly means mega, big, the liver. Hepatomegaly, the liver has gotten big. Hepatomegaly, because you have portal hypertension now. So you have this portal hypertension, increased blood pressure in the portal system, which then causes backflow into the abdominal vessels. So because it's hypertension, blood is backflowing into the abdominal vessel, that abdomen gets distended, and that liver gets bigger, hepatomegaly, okay? And we all know that portal hypertension can lead to ascites, right? What is ascites? It's like that big belly where you can kind of see those veins in there, right? And that's just fluid buildup. Anasarca, anasarca also is another sign and symptom. That's generalized edema, right? Why are you having generalized edema? That's because, look, your blood flow's backing up, right? Anytime something backs up, you can have edema. So that's why you're having it there. Concomitant shortness of breath, because the lung is still involved. So you're still going to have lung-related symptoms. And if there's no blood going in to get oxygenated, then no blood can get pumped out, right? So then the blood supply to the kidneys get decreased. So let's back up. There's not enough blood being circulated. Perfusion to the kidneys now has gone down, right? Because remember, perfusion is enough oxygenation as a result of blood supply not being adequate. So decreased perfusion results as a result of decreased oxygenation due to a decreased blood supply in that particular organ or tissue. So then what happens when you decrease perfusion? Your RAS system kicks in. Renin, okay, angiotensin, aldosterone, to increase fluid retention, to help you retain that volume. And that retention of fluid can lead to edema also. Okay, and because you're having this backup, this congestion, okay, you're going to increase your CVP. You're going to increase your CVP because now pressure is going up, right? If I take a balloon and I fill it with a bunch of water, isn't that pressure going to go up when I try to push that balloon together, right? A little bit of water is kind of squeezable. You put more and it becomes harder. It kind of even pop, right? And it can lead to anorexia. It can lead to anorexia, all right? So how are you going to manage CHF as a nurse? So what are your goals going to be? Well, we know that CHF happens when metabolic demands of the heart goes up, right? It has to work too hard, right? And problems that we see as a result are like edema, right? And so we want to stop the edema, increase circulation, increase the, make it easier for that heart to function and decrease the demands of the heart. So how are you going to do that? Well, how are you going to decrease the demands of the heart? And by making it work less, right? So how can you make it work less? Tell the patient, hey, rest. And your heart doesn't have to work that much, right, when you're resting. That's one thing you can say. If they have a problem with, not enough oxygen at the heart, which is leading to heart failure, always give them oxygen. Supplement them with oxygen. That's an easy thing you can do. Administer diuretics, right? Because fluid overload, we said, can lead to CHF, right? Because it tries to work harder when it has to pump more things around. So give them a diuretic. Help them get rid of some of that excess fluid, right? So a diuretic will help them pee that out. A cardiac glycoside. Well, what do those do? They increase contractility. So if the heart is pumping like this, give them a cardiac glycoside and that'll pump like this. Stronger, right? That's what that'll do. Continuous CVP monitoring, right? Because that can be a complication. CVP can be elevated, so we're going to monitor that and see and keep track of it, right? And make sure you document everything. Oh, palliative management options, right? So what are you going to do there? Well, paracentesis, once again, decrease workload on the heart by removing things, right? A dry phlebotomy, that is when you use a rotating tourniquet, right? And you apply 3 tourniquets on 3 extremities of the body for at least 15 minutes for a total of 45 minutes. Okay, what is that? It's rotating tourniquets, 3 tourniquets on 3 extremities for 15 minutes for a total of 45 minutes. Magic number is 3, right? So 15 times 3 is 45. So 15 minutes for a total of 45 minutes. So what will that do? Well, it'll decrease the venous return of the heart. So if it's less return, that means there's less coming in. That means there's less that has to push out. Heart can work less then. And it'll decrease that cardiac workload as a result of that decreased venous return. Positioning. Well, allow those lungs to expand. What position could you put them in to allow those lungs to expand? A semi-Fowler's position, right? It'll help their lungs to expand and put them on a low sodium and low cholesterol diet. So in CHF management, right, what doctors will sometimes do is prescribe medications to increase the inotropy of the heart, right? Which is just a big fancy word for contractility. Make it work a little stronger, pump a little harder to get that work out, to get that blood flow going. So you're going to stimulate myocardial contractility and produce this inotropic effect. And this is used for short-term management of advanced heart failure, right? So it's going to be a short-term fix to a more advanced problem. So what are the side effects of this? Well, what are you trying to accomplish? You're trying to accomplish making the heart work differently, right? So you have a regular arrhythmia, and if you have a different arrhythmia, that's called a dysrhythmia, right? It's abnormal now. So since you're changing the work of the heart, maybe you made the arrhythmia abnormal as well, so it can lead to dysrhythmia. It can lead to hypotension, okay, because you're going to try to lower blood pressure, right, to make that heart easier, to make the workload on the heart easier. Maybe you lower the blood pressure too much and now you're hypotensive. You have a hypotensive patient. It can also lead to thrombocytopenia, okay, thrombocytopenia. So what are you going to do in this condition? Well, if they're taking medications, you always want to watch for drug reactions. So what are some drug reactions you could have with this? Wheezing, shortness of breath, right? Remember, lung is involved. Wheezing, shortness of breath, pruritus, which is like an itchiness of the skin, and urticaria, which is just like which is, it's like hives. We can break out in hives. That's obviously, something allergic must have happened. Okay, you can also have clammy skin and flushing, okay? And that flushing is due to too much dilation also, kind of goes with hypotension. You'll see flushing and hypotension always kind of go hand in hand, because if you have too much dilation, you might have a flushed appearance, okay? You might have a flushed appearance. Well, these drugs are needing to get to the heart in order to work. Chances are they're probably fat-soluble. If they're fat-soluble, they're going to go to the liver. If they're going to the liver, they're probably going to be hepatotoxic. So you need to monitor their liver function tests, okay? Nursing interventions, what are some things you're going to need to be mindful of? Well, do not dilute any of these things with dextrose-containing solutions, okay? Never do that. And you're going to probably administer these drugs with an infusion pump. And while you use an infusion pump, you have to make sure you monitor their blood pressure, okay? And then you're going to definitely have to keep an eye on whether hypotension or any dysrhythmias occur. Because remember, we talked about those are risk factors, so you need to make sure that does not happen. Monitor the apical pulses and their blood pressure, and since the lungs are involved, assess for wheezing and crackles. And also remember, edema is possible with heart failure, so assess for edema. So we talked about cardiac glycosides briefly earlier. Okay, what are cardiac glycosides? What they do is they are positively inotropic but negatively chronotropic, okay? And they also help you lose some of your volume via diuresis. So what this does is it's going to increase, these cardiac glycosides are going to increase the contractility of the heart, which what that does is it allows enough filling time, right? So enough blood can come into the heart and fill, and this way when that blood is in there, there's more blood in there, that contraction becomes stronger by default, right? So when it becomes stronger, okay, and the contractility goes up, guess what happens to heart rate? What happens with that equation? Stroke volume and heart rate are inversely related. Think about it that way, right? So if my stroke volume is going up, my contractility is going up, I have more blood, my heart rate as a result is going to go down. So these cardiac glycosides lower your heart rate and increase your contractility. A lot of people are like, oh, I don't know that. They memorize these equations. They never understand those equations, and these things like this become complicated to them. And those are the nurses that are more prone to making mistakes because they memorize something out of a textbook instead of understanding it. Common cardiac glycosides are digitalis and digoxin, digitalis and digoxin, digitalis and digoxin. One thing you should know is there are lots of side effects associated with these drugs. Okay, so what are some of these side effects? Well, we said the heart rate's going to go down, so maybe it goes down too much, now you're bradycardic. You have a bradycardic patient. Hypokalemia is also a side effect, and we talked about why in the electrolyte lectures, so make sure you know how to make that connection, okay? It can also lead to nausea, vomiting, and anorexia. And they can actually end up having blurred vision, actually blurred yellow vision and diarrhea. Okay, blurred yellow vision or blurred vision and diarrhea. So when you see all these side effects and you tell your doctor's going to put them probably on a drug called Digi-Immune Fab, which is going to help counter the effects of that digitalis, okay? Nursing interventions. Well, what are you going to do as a nurse? Well, these medications, right, need to be given with meals at the same time every single day. Given with meals at the same time every single day. And because hypokalemia is a possible side effect and medicine with potassium always messes with your QT interval and you already have a heart patient, right, you're going to have to monitor those potassium levels and check their pulse before you give them the medication, because if their pulse is too low already, they're already bradycardic, let's say, or they're already hypokalemic, this drug could really cause a serious complication. Hold if less than the, for adults, childs, or infants is different heart rates, okay, so we're going to go in alphabetical order, ACI, 60, 70, 90, okay, adult is 60, child is 70, infant is 90, okay, ACI, 60, 70, 90, go in alphabetical order and numerical order, 60, 70, 90, ACI, adult 60, child 70, infants 90. Cardiogenic shock. Let's talk about cardiogenic shock. What is cardiogenic shock? Well, this is also failure of the heart to pump adequately, and as a result of this, cardiac output goes down, and if cardiac output goes down, there's not enough blood coming out, right? That's what it means. That means perfusion is going to be compromised, okay? So, cardiogenic shock will lead to necrosis, okay, of the left ventricle, and that left ventricle necrosis is secondary to occlusion of these major coronary vessels, okay? Cardiogenic shock presents with hypotension, like most shock does, right? And we talk about those drugs we give to tighten those vessels and get that blood pressure back up. It also presents with decreased urine output, because now you're trying to save what volume you have, and so you're going to decrease your urine output, and as a result, you're going to have cold and clammy skin. You're going to have less flow, less perfusion, so they're going to have poor peripheral pulses. They're going to have less blood flow there, so those pulses are not going to be as strong as they used to be. As a result of this hypotension, your body's going to react by doing what? Raising your heart rate, so you can become tachycardic. That can be a presentation. Because of this buildup, because the heart's not pumping right, you can have pulmonary congestion and pulmonary-related symptoms. Right? You can have chest discomfort then. And you can become disoriented and restless and confused because of the effects this poor perfusion may have on your brain. Now, as you become tachycardic, okay, and as you get this congestion, your body says, okay, I need to breathe faster, breathe faster, breathe faster. And that respiratory rate increases not only because of that, but also because you will eventually develop metabolic acidosis from shock. So this cardiogenic shock can lead to metabolic acidosis, causing an increased respiratory rate. So what are you going to do as a nurse if somebody has cardiogenic shock? Well, you're going to have to prepare the patient, okay, for an intra-aortic balloon pump, okay, an intra-aortic balloon pump. You're going to have to give them oxygen. Always going to have, normally when a heart's involved, you're going to have to give oxygen. And as a result, on this one, you have to monitor the ABGs, the blood gases, okay, and if there are any imbalances in those blood gas readings, you're going to have to be prepared to treat those imbalances. You're going to monitor the urine output, right, because volume now is of concern, right? You want to preserve volume, but you also want to have some urine output, right? So you want to make sure they have at least 30 milliliters an hour, 30 milliliters an hour. What are some common medications given to patients with cardiogenic shock? Well, morphine sulfate can be given via an IV, morphine sulfate via an IV, and that's not given, okay, for pain. It is given for pain, but it's also given to decrease this pulmonary congestion, And because volume is of concern here, right, and you're going to be holding on to it, right, you don't want to hold on to all of it, you still want to be peeing, and if they're not, we're going to give them some diuretics, okay, to help them pee a little more, and some nitrates, right, to lower that blood pressure by causing vasodilation. We can also give vasopressors and some positive inotropic agents like we talked about with heart failure to maintain perfusion, right? So you can increase contractility, right, to help make sure all that blood is getting to where it needs to go. Cardiac dysrhythmias, that just means it's not normal anymore, so let's talk about normal first. What's normal sinus rhythm? Atrial and ventricular rhythms are regular, and sinus rhythm normal rate of the heart is 60 to 100 beats a minute. And because it's a normal sinus rhythm, right, there's not going to be any abnormality on the EKG, so your PR interval and your QRS widths are going to be within normal limits. Sinus bradycardia means it's too slow, okay, the heart rate is too slow, so the atrial and ventricular rhythm is okay, we're just beating too slow, so instead of 60 to 100, right, that's normal, it's going to be below 60 beats a minute. PR interval and QRS will be within normal limits, okay, and this will normally only be treated if the patient is symptomatic. And so you'll have to figure out what's going on and then give them some oxygen to supplement and then give them atropine, right, to help get that heart rate back up. Sinus tachycardia is the opposite. That's when heart rate is too fast, right? And so your atrial and ventricular rhythms are still normal, right? But now your rate is over 100 beats a minute, over 180, okay? Your PR and QRS are still within normal limits, but you'll have to identify what's causing this tachycardia and then treat that accordingly. AFib, okay, AFib or atrial fibrillation is when the atria quivers. Because of this arrhythmia, you're at risk for clot formation, okay, and because the P wave is representative of the atria in the EKG, you're not going to see a definitive P wave. And so since you're at risk, your patient is at risk for a clot formation as discussed, we're going to have to give them anticoagulants and cardiac meds as ordered by the physician and prepare them for cardioversion to get them back into normal sinus rhythm. PVC, what's PVC? That's a premature ventricular contraction. It's happening too early, okay? So you're going to have bigeminy, which is 2, trigeminy 3, or quadriminy 4. Okay, so here's an EKG of PVC, so take a look at how they look, okay? And most of the causes for these heart abnormalities, like I said, are going to be hypoxia, right? So hypoxia can be a cause, or hypokalemia. Anytime you mess with potassium, mess with that QT interval, and there's your ventricles involved in that QT interval, right? So you're going to have to, if somebody has PVCs, what you're going to do is you're definitely going to have to notify your physician, okay, patient physician, if they complain of chest pain, and if they have more PVCs than normal, or if they have runs of ventricular tachycardia, so tachy, fast ventricular rhythm, okay? So that'll lead us right into ventricular tachycardia, and what is that exactly? Well, that's when the ventricular rate is 140 to 250 beats a minute. That's just really, really fast. So if the patient is stable and has a pulse that shows no signs or symptoms or decreased cardiac output, right, you're going to just give them oxygen and give them these anti-dysrhythmic meds, these medications to get their arrhythmias back in check, back to normal sinus rhythm. So if it's stable, you know, just oxygen and meds are fine. If the patient is unstable and has a pulse and shows signs of decreased cardiac output, apply oxygen and give medication, but once again, cardioversion may be used, so prepare them for cardioversion to get them back into that normal sinus rhythm. And you might have to perform CPR if they're not perfusing, so you might have to perform CPR there. If the patient is pulseless, chances are you're going to have to defibrillate them and begin CPR also, right? dysrhythmia. So if they have a dysrhythmia, how are you going to manage that as a nurse? Well, if they have VFib, right? What is VFib? That's when we said the ventricular fibrillation. That means it's a chaotic or rapid rhythm, right? That means there's no cardiac output because they're not pumping right? And this arrhythmia, this dysrhythmia can be fatal if it's not corrected within 3 to 5 minutes. The patient normally, in this case, will lack a pulse and blood pressure will be low, the respirations will be abnormal, and heart sounds, okay? So they're going to lack a pulse, lack blood pressure, lack respirations, and lack adequate heart sounds. So what are you going to do as a nurse? As a nurse, you're going to have to defibrillate them immediately and get them going again, okay? Up to 3 times consecutively at 200, 300, and 360 joules, okay? Have the defib immediately, 3 times consecutively, 200, 300, and 600 joules, and begin CPR. Apply oxygen like you always should, and then give them that antidysrhythmic medication. Antidysrhythmic medications, what are they? Well, they're given to get these dysrhythmias, these variations in cardiac rate and rhythm back to normal, right? So the side effects of these. Well, because you're messing with the rhythm of the heart, okay, you're going to mess with these vessels, you can lead to hypotension, orthostatic hypotension, dizziness because you're messing with flow, and nausea, vomiting, and vasodilation. You should know that already because vasodilation is going to be the reason why you're having orthostatic hypotension, all right? And signs and symptoms of toxicity, if this medication is toxic to them, you're going to see diarrhea, so keep an eye on that. All right, so let's talk now about vagal maneuvers, okay? Remember the vagus nerve, okay, is the largest nerve for the parasympathetic system, and it normally slows things down, so it's going to slow down your heart rate, okay? So what is a vagal maneuver? So you're going to induce this vagal stimulation, and you're going to use this to terminate supraventricular tachydysarrhythmias. Well, what did I just tell you? The vagal nerve slows things down, right? So what's an SVT? That means it's too fast. You're going to stimulate the vagus nerve to get it to be slower, okay? So it involves a carotid sinus massage and a Valsalva maneuver. What's the Valsalva maneuver? A Valsalva maneuver is simply when you bear down, right? Like when you're taking a dump, okay? That's a Valsalva maneuver you just did. Always keep the defibrillator and the resuscitative equipment at the bedside while you do the vagal maneuver, because if you stimulate it too much, it could end up being a complication. You might slow it down a little too much and lead to a bradycardic type of related crisis, okay? You may also be required to do paddle electrode placement. And the way they might ask you this question on the NCLEX is going to be by, it's like a hotspot question. We have to kind of mark where it needs to go, okay? It goes in the third intercostal space to the right of the sternum. In the third intercostal space to the right of the sternum. And the second paddle is placed at the 5th intercostal space to the left of the mid axillary line. First one, 3rd intercostal space, okay, right of the sternum. Second one is 2, add 2 to 3, so you get 5th intercostal space now at the mid axillary line on the left side of it, right? How much pressure do you need? You need 25 pounds of pressure to apply to these conductive pads, right? And make sure nobody is touching that bed. This is electricity, right? Electricity. So cardioversion is to get that sinus rhythm back to normal. So return the patient back to normal sinus rhythm, okay? So how are you going to do that? Well, this cardioversion does that by, it's like a synchronized lower amount of energy compared to a defibrillator. Okay, so a defibrillator is higher energy, not as synchronized as this cardioversion. So make sure the skin is clean and dry before applying the paddle, because if it's wet, guess what's going to happen? You're going to shock the hell out of your patient, okay? So make sure the skin is clean and dry before applying the paddles, and if it's successful, they'll go back to normal sinus rhythm, which is the goal, and you'll have strong pulses in the periphery again, normal blood pressure, and you'll see adequate urine output, okay? Defibrillation, okay, that's an asynchronous counter shock, okay? And so this is used in people who are pulseless, have ventricular tachycardias, and VFib, okay? You got to do it quickly, get it back. So you have 2 types of defibrillators. Okay, you have a monophasic, which means that it's going to be energies going in one direction. Mono means one, like a monocolored TV is a black and white TV, right? So it's going to be going in one direction, and you're going to have to immediately begin CPR. Biphasic means energy goes in 2 directions. Energy goes in 2 directions. So what are you going to do as a nurse if you're going to have to do either one of these procedures or be in the room for them? Well, turn off all oxygen, okay? And make sure no one is touching the bed, once again, okay? It's very important. So it's important to know what kind of devices you might use to accomplish this cardioversion or this defibrillation, right? So we have this automatic external defibrillator, abbreviated AED, And this is used by the general public in emergency medical texts, right? And it's really simple to use. All you're going to do is place them on a dry, hard surface. Place the patient on a dry, hard surface because it's electricity, right? You don't want to shock them. So place them on a dry, hard surface and apply patches to the correct positions, as we mentioned earlier. And these shocks are only recommended for people who are pulseless VTAC or VFib. Pulseless VTAC or VFib. Implantable cardioverter defibrillator. This is an ICD. This will actually detect your VTAC and your VFib. And so this transvenous electrode is placed by the right atrium. It's in the right atrium and ventricle. It's actually in contact with the endocardium in those regions. And these leads will then sense and pace the delivery of this cardioversion or defibrillation. Tell your patient, avoid sports to prevent trauma to this implantable device. Report any type of fever because that could be a sign of infection. Also redness, swelling, and drainage, also signs of infection, right? So tell your patient to be wary of those, especially that drainage from the incision site, right, or the insertion site, sorry. Report symptoms of fainting, nausea, weakness. Those are things that you don't want people to experience generally, but if somebody has an ICD, that could be a sign of a complication, as well as blackouts or a rapid pulse. That pulse has gotten out of control now. You need to tell them to, let somebody know. Avoid electromagnetic fields because that's going to mess with the electricity and that charge that ICD might give out. Okay, so you always see these little warning signs of people who have these ICDs. Tell a patient to keep a log of the date, time, and what they were doing when they had an attack, and then what symptoms they had before the shock and what they had after the shock. Okay, tell them to keep a log of all that stuff. Remember, documentation is also important for the patient in this case who has the device. Nursing interventions for pacemakers. Well, if it's a invasive transvenous pacing, the lead wire is going to be in the antecubital femoral, jugular, or subclavian vein into the right atrium. Into the right atrium or right ventricle. Right atrium or right ventricle. Okay, right atrium, right ventricle. So you're going to make sure they restrict their movements. Okay, we don't want that to be dislodged. Non-invasive transcutaneous pacing. This is make sure they wash their skin with soap and water before you apply that electrode. Make sure it's a clean, dry surface. Okay. The back electrode needs to be between the spine and the left scapula. The spine and the left scapula, okay? And that'll be behind the heart, in between the spine and left scapula. And don't place it over the bone. Avoid placing that over the bone. The anterior electrode will be between V2 and V5, okay? Between V2 and V5, and you're going to need to evaluate and treat pain if they have it, okay? Invasive epicardial pacing has a reduced risk of microshock, like little shock. These are exposed but insulated wires, and they're what you'll do is you'll insulate exposed wires with plastic or rubber material. Okay, so this way that exposed wire doesn't lead to electrical complications. And you'll cover it with non-conductive tape once again to avoid electrical complications. And you need to ground all electrical components with three prongs. Okay. So let's talk about angina or angina. I've always called it angina. Some people call it angina. I don't know which one's right. I blame it on my, my ESL teacher. English wasn't my first language. I used to talk like this. Transient paroxysmal substernal upper cordial pain. Now, what is that? So, this is something your patient is going to come and describe to you as like a heaviness or tightness in this chest. It's important to pay attention to them because they can kind of present like indigestion-like symptoms, okay, or like a crushing feeling, like something's being crushed or heavy in their heart. The difference between angina and MI is really the EKG, okay? MI is when you've had like necrosis and it's irreversible. It can be irreversible. Angina is always reversible, right? And it's kind of a transient thing. Angina also can be relieved by rest and nitro, while MI cannot, because angina sometimes and oftentimes happens with exertion. So if you just tell that patient to relax, those symptoms will subside. And giving nitro to cause vasodilation immediately may relieve those symptoms, and that might be indicative of an angina if you give it to them and it works. Okay, MI, you cannot use those as treatments or to alleviate symptoms. Signs and symptoms: pallor and diaphoresis. Okay. Dyspnea is also one because they're going to have trouble breathing. They may faint. They have like a faint feeling, right, or palpitations as a result of the problem in the heart and the lack of flow and perfusion, as well as they can become dizzy because, once again, lack of perfusion, as we mentioned, throughout this cardiac lecture. So all these signs and symptoms should start kind of having a pattern to you, okay? And most of these side effects, this dizziness especially, is secondary, right, to decrease blood supply to the brain. And then you have the palpitation as a decreased blood supply to the heart. Like I said already, angina can be described as a crushing or indigestion type of feeling. You're going to monitor their enzymes, okay, and usually they're going to be negative with angina because tissue ischemia has not yet occurred. Once ischemia occurs, we call that an MI, and that's when the enzymes will really be elevated. And this is not happening, so the enzymes will be normal. How are you going to manage this? Well, I already told you, so most of the time it happens to patients upon exertion, so have them rest. Give them oxygen supplements and nitrate therapy, we've already discussed. Types of angina, or angina, right? Stable or exertional dyspnea, stable or exertional angina. What is this? Well, this is chest pain that lasts for about 15 minutes, and it's relieved by rest, and the recurrence of this is less frequent, okay? So it doesn't happen as often as some of the other ones, and it's relieved by rest because, remember, another name for stable is exertional. So stop the exertion, and that angina that lasts about 15 minutes will subside. Unstable, this is a pre-infarction angina. Unstable is a little more serious, right, because it's not stable. It's kind of in the name. They can sometimes call this a crescendo angina or an intermittent coronary syndrome. And this is, since stable is 15 minutes, this is now unstable. So this will be pain lasting more than 15 minutes or symptoms lasting more than 15 minutes. But it's still less than 30, so it's between 15 and 30 minutes. And now the recurrence is more frequent, and it may actually happen at night. And because it's unpredictable, it is unpredictable, and pain may not be relieved with nitroglycerin, since it's a little more serious than the previous one. And unstable can occur at night, but nocturnal is the one that always occurs at night, right? Nocturnal means night. So it occurs at night and is associated with REM, so REM sleep, which means rapid eye movement. Okay, and so that's your nocturnal angina if it occurs during REM at night. So it's going to happen at night, like I said, associated with REM sleep. Resting angina or angina, this is rather worrisome, okay, because this is something that can happen to somebody who's in a sitting or resting position. And precipitating factors for this resting angina are the 4 E's, okay? Exertion can be one, okay, even though they're resting. Emotion's another one, though. Eating a heavy meal is another one. And their environment, such as being exposed to something that's really cold, right? So exertion is one, okay, and that's, that makes it a little more predictable, but if it's emotion, eating a heavy meal, or environmental, that can be a little more unpredictable. So we talked about angina. Before we talk about myocardial infarcts, let's talk about some anti-anginal medications. Nitrates we talked about. They work by increasing cyclic GMP, making you more parasympathetic and causing vasodilation, taking that workload off the heart, allowing that heart to return back to normal, and getting rid of that tightness which they may present with. That nitrate by causing vasodilation is going to decrease their preload and afterload, make it much easier for the heart to work, and reduce myocardial heart oxygen consumption, so it's going to make that heart have a decreased metabolic demands. This is contraindicated in a patient who has hypotension. Why is that? Because a patient with hypotension probably already is on a vasodilator, and even if they're not, they already have vasodilation. You cause more vasodilation with a nitrate, guess what happened? You probably killed your patient, okay? And remember, as a nurse, worst case scenario always, and keep your patient alive, and document anything. Prevent the death, and document everything. The 2 Ds as a nurse, and you'll be fine, all right? Side effects of these medications. So here's the concept I want to bring up, and I want you to know. We're going to talk about headache for a second. They did a study recently in the ER, and they said that most migraines can be treated effectively, 80% of them, by giving oxygen. Why is that? Because oxygen in your brain, okay, causes vasoconstriction. So if you're giving oxygen to treat a headache or a migraine, okay, it's going to cause vasoconstriction. Is that headache due to vasodilation normally or vasoconstriction? Headaches are due to vasodilation, which is why you give oxygen now to cause vasoconstriction in that brain and get rid of that migraine. 80% of patients with migraines say that that migraine subsided without any medication when oxygen was administered in the ER. It was a doctor that decided to try it. I guess he paid attention to physiology. So now let's think about it. If headaches are caused by vasodilation and nitrates are causing vasodilation, wouldn't you then be able to deduce that nitrates, due to vasodilation, can have headaches as a side effect? And they in fact do. And since they're causing vasodilation, okay, they can also cause orthostatic hypotension. We've gone over that concept a few times already. Because of this vasodilation, this headache, and this, blood flow to the brain being changed, you can have dizziness. Okay, the patient can become weak or faint. Okay, and they can also have nausea and vomiting as a result of this medication. Now, I told you what always goes with hypotension: flushing due to dilation. So flushing is also on this list. And because they're dizzy and they're confused, right? They're dizzy and they're confused now because blood flow is being changed. Some other things that you want to keep in mind are because anytime they have hypotension, what's going to happen? You're going to have a reflex tachycardia. Heart rate's going to go up. But also for this one, keep in mind that they might have a dry mouth. Remember, lots of nitro is given sublingual, okay? Never abruptly stop this medication. You don't want to lead to any kind of rebound crisis. So tell your patient to check these nitro tablets and the expiration date because they're normally going to expire within 6 months. So if it's a nitrate tab, it's about 6 months, but sometimes nitroglycerin, which is a different form of nitro, is going to be given sublingual. Okay, so if the tablets have expired, it's not going to relieve that chest pain. So it's very important to make sure that it hasn't expired. Angina then leads, if it leads to, like I said, angina has no ischemia. MI does have ischemia, so let's talk about MI, or myocardial infarct. What happens here is you have necrosis now. You have ischemia leading to necrosis within the myocardium, and it usually follows an unmanaged angina if it's not managed appropriately, right? So it can progress to causing ischemia and eventually necrosis. There is obstruction to one or several of the blood vessels of the heart, which is why you have this prolonged ischemia. All ischemia is you're not getting adequate flow and oxygenation, and so something is obstructing it, like a plaque in the heart, whether it's cholesterol-related plaques or fat-related plaques, or if it's just narrowing of the vessels due to smoking or things of that nature, right? Now you have something that's going to last more than 35 to 45 minutes, okay? It's going to last more than 35 to 45 minutes, and it's going to produce irreversible cellular damage and necrosis, which is death of the myocardium. So signs and symptoms, we're going to talk about the enzymes in detail later, okay? But you are going to have elevated enzymes in an MI, not really in an angina, right? But you are going to have them here. Enzymes you're going to check are going to be your CK, your creatinine kinase, your CKMB, your troponin 1, and your troponin T, okay? And we'll talk about those in detail here in a little bit. The thing about MI is you're going to have different symptoms and pain-related symptoms that will not necessarily be localized to the chest. So like a radiating or a crushing pain, as well as nausea and vomiting. And one thing to really keep in mind is that these symptoms can really be nonspecific in females, okay? So keep that in mind. They can really present quite differently if they're female. They can also have a low-grade fever, which is secondary to the inflammatory effects of the MI. Because remember, anytime there's a cellular process going on, your body's going to react by causing inflammation in that area, so you can have a low-grade fever. EKG changes, you're going to see, so you can have a Q wave change, inverted T wave, or ST elevation, okay? So I told you we're going to talk about those enzymes, right, that will be elevated in MI, but not in angina. So let's talk now about these enzymes. Your creatinine kinase of your myocardial muscle. So anytime your muscle breaks down, your CK will go up. So you're going to check CKMB, which is a little more specific for the heart, okay? So if CKMB is up, that means that it's indicative of myocardial damage. It occurs within hours of the attack, and it's normal if it's within 0 to 5% of the normal range, okay, which is going to be within that 28 to 174. And you'll get those lab values, but just know that CKMB is something that's going to be checked, okay, and that's going to occur within hours of the attack. It's very important to know when these enzymes will be elevated. So CKMB within hours. So we talked about creatinine kinase, the myocardial muscle, okay, it rises within hours of the attack. Let's talk about myoglobin, okay. Now myoglobin, this is an oxygen-binding protein, right? We learned this probably when you guys talked about hematology. All right, this myoglobin is an oxygen-binding protein that's in cardiac and skeletal muscle. Now, this will rise within 2 hours. You have CKMB within hours, and now you have myoglobin within 2 hours of cell death. So when that MI starts and the necrosis starts, within 2 hours, you're going to see an increase in myoglobin in the, on your lab values. The thing about myoglobin is that it will decline after 7 hours. So you have from 2 to 7 hours. You have a 5-hour window when this myoglobin level will be elevated. You're also going to look at troponin, and troponin is composed of 3 proteins. There's a troponin C, a troponin I, and a troponin T. Okay, so CIT. Now, troponin I. So think about infarction, myocardial infarction I. So troponin I is the one that's linked with myocardial injury. So injury I, infarction I, troponin I. Okay. This is going to rise within 3 hours. So now we have CKMB within hours, myoglobin within 2, and this now within 3. Okay, within 3 hours. But troponin is going to stay for 7 to 10 days. Okay, so if they have it in MI and it wasn't diagnosed before, and now they're into the hospital, 7 to 10 days later, that value will no longer be elevated. Okay, troponin I is normal if it's less than 0.6 nanograms per milliliter, and troponin T is from 0 to 0.2. So troponin I is from 0 to 0.6, and troponin T is from 0 to 0.2. You're also going to check lactase dehydrogenase, and this can be rather nonspecific at times. These elevations will happen within 24 hours and peak in 2 to 3 days. So it'll happen in about 1 day and peak in about 2 to 3 days. Now, normally your your LDH1 will be lower than your LDH2. If it's higher, then it's considered flipped. So now your 2 is lower than your 1. So your 1 has now gone up. Okay, and that's considered flipped, and that means you now have it's indicative of myocardial necrosis. A normal value for lactate dehydrogenase is between 140 and 280. So in addition to these enzymes, once you have confirmed that your patient has had an MI, or the doctor has confirmed it, what are you going to do as a nurse? Well, they're going to have pain, right? Because that's necrosis. Necrosis is always related to pain. So you're going to have to give them something for pain management, right? And you want to decrease their cardiac output, right? Because now you don't want you don't want that heart to be more stressed than it already is, right? And now parts of it are dying. It's at inadequate blood supply. So you want to decrease the cardiac output, take some pressure off that chest, right? I mean, off that heart. They will also administer, or you will also have to administer most likely anticoagulants, right? Anticoagulants are going to help from clots from forming, and prevent clots from forming. And this way, you don't have further impediment to blood flow, leading to further ischemia or necrosis and exacerbating that MI. And so remember that one of the best antiplatelet drugs is aspirin. That's why a lot of MI patients will take baby aspirin. 81 milligrams a day is sufficient. Okay, and that's baby aspirin, 81 milligrams a day. MI, always concerned with ischemia. So the first thing you're going to do is slap an oxygen mask on their face to supplement them with oxygen. And once again, you want to decrease their overall demand, decrease the amount of work that the heart has to do, right? So what you're going to do is set bed rest, decrease oxygen demand on the heart, okay? Since they had an MI, they had risk factors. We want to get rid of some of those risk factors. So tell them to have a low sodium, low fat diet, right? So you're going to make sure they're doing that. And then if you can catch this within 6 hours of the MI, okay, you're going to give a thrombolytic therapy. These PACE drugs like Altiplase and TPA, those type of thrombolytic drugs, okay? If it's an MI, it needs to be within the first 6 hours. If it's a stroke, within the first 3 hours, okay? So thrombolytics within the first 6 hours of an MI, okay? 3 hours of a stroke. And the way I remember that, a stroke is 1 word, so that's 3. MI is 2 words, so multiply that by 2 and you have 6, okay? So 6 hours with an MI, 3 hours within a stroke. We talked about beta blockers earlier, okay, with hypertension, but this is really just a recap of them. So this will reduce the cardiac output and decrease the sympathetic response, which is normally a tightening of the vessel's response. It'll prevent that tightening. It blocks the beta receptors, hence the name beta blocker. And remember, all those end in LOL. And because it blocks the beta receptor, it'll decrease their blood pressure. And like I said right here, medications end in OLOL. It's used for hypertension, MI, and angina. And adverse effects of this is, we talked about the receptor earlier, bradycardia, hypotension, and also hypoglycemia. Why is that? Because the beta-2 receptor is responsible for increasing insulin. Okay? So it can cause, if you block that, it'll cause a decrease in insulin. That's why a lot of beta blockers are contraindicated in diabetes. So that's something to keep an eye out for, okay? Here are your contraindications. Patients with asthma, why? Because your beta receptors are responsible for bronchodilation. If you block it, you're going to make bronchoconstriction happen, and so asthmatics find it even harder to breathe. Bradycardia, why? Because a beta blocker is going to slow down your heart rate, so you can't give it to a bradycardic patient. Beta receptors normally increase contractility. If you block it, you're going to decrease contractility, and so it's contraindicated in heart failure patients. Beta receptors are also responsible for increasing renin, especially beta-1, so it's contraindicated in people who have renal problems or hepatic problems. And it's also contraindicated in people who have hyperthyroidism or stroke. All right? Always check blood pressure and pulse, since these are two things directly affected by these types of medications. And like we already mentioned, they have orthostatic hypotension, so assess them for that. Calcium channel blockers, okay? Calcium channel blockers are going to decrease the cardiac workload and make it easier for your heart to work by taking some of that pressure off of it. These medications end in dipines, okay? These dipines are the vasoselective ones. The other two are verapamil and diltiazem. Now, why are calcium channel blockers important? Well, they're used a lot, but also because of side effects. Remember this. You have a thing called gastrin, okay? And what that does is increases gut motility. Gastrin uses calcium as a second messenger. So you have gastrin, which increases gut motility, and if you increase gut motility, you poop more, right? Now, if I block gastrin, okay, or by blocking calcium, because now gastrin can no longer convey its message to increase gut motility, I've blocked calcium with this calcium channel blocker, the gut motility has now been reduced. If gut motility is reduced, constipation is going to be a side effect, okay? So side effects of these calcium channel blockers are going to be bradycardia and hypotension, okay? Also headache, dizziness, fatigue, constipation, peripheral edema, and flushing of the skin. Calcium channel blockers are used to treat angina, dysrhythmias, as well as hypertension. Blood coagulation factors, okay, they'll increase during an MI, and they cause a greater risk for this thrombophlebitis, which is, a thrombus, right? And it can also cause an extension of clots in your coronary arteries. So this is important, and so this will take us right into our discussion of anticoagulants. So continuing on our discussion of cardiac pharm, okay, we talked about the calcium channel blockers. Let's not talk about anticoagulants. So what are anticoagulants? Well, coagulation means the formation of a clot. So anticoagulant means disrupting the process of clot formation. Now, why is that important? Because when a clot forms, remember, we're going to impede blood flow. We're going to lead to ischemia then and lead to imbalance between perfusion and oxygen demand, right? So the main function of anticoagulants is to prevent these clots from forming, okay? And also from preventing clots that have already formed from getting bigger. So in MIs, we're giving them preventing additional clots as well as preventing that clot from getting bigger. Now, these work by interfering with the clotting cascade and as well as formation of fibrin formation. So they interfere with fibrin formation as well. So keep in mind that these do not actually break up the clot or lyse the clot. They just prevent it from forming, okay? So let's talk about some common anticoagulants. Well, one thing to know is there are two main coagulants which you'll use. That's heparin and warfarin, okay? So one's used for acute conditions, one's used for chronic conditions, all right? Which one comes first in the alphabet, acute or chronic? Acute, okay? Which one comes first in the alphabet, heparin or warfarin? Heparin. So we use heparin for acute conditions, warfarin for chronic conditions. So anything that's long-term, warfarin, short-term, heparin, okay? So think about it that way. Which one has a longer half-life? Warfarin does. Which one has a shorter half-life? Heparin does. Once again, alphabetical order, right? And which one's going to have more side effects? Probably warfarin, right? Because it's longer half-life, it's more fat-soluble, it can get to where it needs to go and stay there. So let's talk about heparin first. So heparin, when you administer heparin, okay, you're going to have to check these lab values every 60 to 70 seconds. Okay, every 60 to 70 seconds, and check the PTT and APTT. Okay, so the PTT and the activated PTT. Okay, if you give somebody heparin and they have too much heparin or heparin-induced thrombocytopenia, right? You can give protamine sulfate as an antidote. So the antidote to heparin is protamine sulfate. The antidote to heparin is protamine sulfate, okay? Now, heparin, sometimes it causes side effects like HIT, right? Heparin-induced thrombocytopenia. So they'll give low molecular weight heparin instead. So you'll administer low molecular weight heparin instead because it has less side effects, less chance of causing HIT. So how are you going to remember all of them? Well, they all end in parin. They all end in parin, okay? So that should be a trick for you to help you remember that. Coumadin is warfarin. Warfarin is Coumadin, okay? So the brand name is Coumadin. It's actually generic as warfarin. Now, warfarin interferes with vitamin K. And vitamin K has several clotting factors associated with it. So by interfering with vitamin K, you thereby interfere with the clotting cascade, okay? So for warfarin, you're going to check the INR and the PT. INR and PT, normal value is about 1, and the therapeutic index is 1.5 to 2.5. Since you're trying to block vitamin K, right, that's the goal of this drug, it makes sense then to avoid foods that are rich in vitamin K, such as kale, spinach, collards, turnips, green leafy vegetables, right, that have vitamin K. Side effects for these drugs since you're trying to prevent clot formation, what's the opposite of that, right? No clot formation. If you don't have a clot forming, you're going to bleed. Also, if the patient has diarrhea, that means that they're probably at a high risk for toxicity. That's a way to gauge that toxicity by seeing if they're diuretic, by seeing if they have diarrhea or not. So nursing intervention. So what are you going to do to prevent the side effects of these medications if somebody's on an anticoagulant? So your goal is to prevent bleeding, right? So you're going to place them on bleeding precautions, such as soft bristle toothbrush, so they don't cut up their gums and start bleeding, because we're not going to be able to clot, right? Because we're using anticoagulants. If they start bleeding, they're going to keep bleeding, and we don't want that, right? So soft bristle toothbrush. Should they use a regular razor or electric one? Or electric one, because they're not going to get cut as often, right? Or the risk isn't as high. Make sure you monitor the PT, the PTT, and the INR, like we already said. Avoid taking aspirin, because that is going to do what? It's also an anticoagulant, right? So now you're going to make that happen again. And you're going to anticoagulant, too much bleeding going to happen, okay? Avoid aspirin-based substances as well as NSAIDs. Avoid alcohol, because alcohol negatively affects the liver, and these drugs are dependent on the liver. They are fat-soluble drugs, okay? They depend on the CP450 system. So avoid alcohol because it's going to mess with the liver. Other things you want to avoid are going to be drugs that mess with CP450, okay? And some of those drugs are going to be like cimetidine, okay? That's H2 block that might be used in GI patients. Also going to want to avoid corticosteroids, like I said. Another drug called allopurinol, which is used for gout. Also going to want to avoid those green leafy vegetables and things that contain vitamin K. We already said avoid NSAIDs. We want to also avoid oral hypoglycemic agents. And phenytoin. Phenytoin is another drug that's going to mess with CP450. As well as sulfonamides and ginkgo and ginseng, okay? So some things to keep in mind there if you're a nurse treating somebody on an anticoagulant. And keep in mind, lots of patients are on anticoagulants, okay? Antiplatelet medications, these are going to inhibit the aggregation of platelets in the clotting process, okay? And they're used prophylactically following an MI, right? So that's why a lot of people who are at risk of an MI, who have already had an MI, are given aspirin. 81 milligrams is more than sufficient. That's a baby aspirin dose, right? 81 milligrams, and that is, in fact, the most effective antiplatelet medication. People who are on who have stents or strokes may also be taking antiplatelet meds, but they might be taking something like clopidogrel or Plavix, okay, which is a different kind of antiplatelet med. Side effects of this, okay, these medications tend to be hard on your stomach, so it might cause a GI bleed, and because you're at increased risk of bleeding, once again, you can have blood in your urine, like hematuria, or blood in your stool, which is called melena, look like tarry stools, as well as easy bruising. Nursing interventions for somebody on antiplatelet medication include monitoring their vital signs, and take the medication with food if the patient. Tell the patient to take the medication with food if they have an upset stomach, right? Because it's kind of hard on the GI. Common medications that are used are going to be abciximab, and that's actually an antibody towards the glycoproteins, which are used to kind of help platelets aggregate. Aspirin, which we mentioned. Cilastazol, clopidogrel, which we mentioned. Ticlopidine, also, as well as tirofiban. Now, ticlopidine and clopidogrel are both in the same category there, and they'll mostly used with stents, okay? Clopidogrel mostly is more common because ticlopidine has quite a few side effects associated with it. So if somebody is on ticlopidine, you might want to monitor them for seizures and agranulocytosis, okay? Thrombolytic medications. Remember we said thrombolytic medications are given to people in the first 3 hours of a stroke or the first 6 hours of an MI, right? So main function is to dissolve an existing clot. So anticoagulants prevent them from forming or becoming bigger. Thrombolytics break up the clot. They lyse that clot. Must be given within 6 to 8 hours of an MI, CVA, or pulmonary embolism to get the maximal effect. That's the golden period, 6 to 8 hours for those conditions. If it's a stroke, it needs to be within 3 hours. Common examples are streptokinase and alteplase, aka TPA. Side effects, you got to worry about allergic reactions here. And they're going to be at high risk of bleeding once again because you're breaking up these clots. And so if there was a clot preventing bleeding somewhere, you can disrupt that clot and get that blood flow going again and lead to bleeding. Okay, it also can cause low-grade fever. It's contraindicated in people who have active bleeding or brain bleeding. Okay, so if they already have an active bleed, you don't want to disrupt the clot that might be forming, okay, or has already formed. As a nurse, you're going to also check their PTT. Check their vital signs, and always have an antidote at the bedside, okay? So let's review these antidotes again. So We said heparin's antidote was protamine sulfate. The antidote to warfarin is vitamin K because that's what you're trying to inhibit, so you just give them vitamin K and reverse that warfarin. The antidote for thrombolytic medications is aminocaproic acid, okay? So keep that in mind as well. Let's talk about aortic aneurysms. This is a serious condition, and we're talking about the aorta as it runs down in the abdominal area, okay? This will be, an aneurysm is a permanent but localized dilation of an artery. So the artery just enlarges and it stays dilated. So how can you see if the artery is dilated? Well, you're going to do like an abdominal ultrasound to see it, maybe a CT scan, or sometimes they'll even do an arteriography, okay? Now, how do you assess a patient that has abdominal aortic aneurysm? Well, first of all, this is a very painful event. So they'll have abdominal pain, flank pain, and back pain. Abdominal pain, flank pain. Okay, this is flank pain right here, right? Abdominal pain, flank pain, as well as back pain. So abdominal, flank, and back. If they have severe lower back pain, okay, that's going to be indicative of a tear, an abdominal. It's a AAA tear, so abdominal aortic aneurysm that is actually torn. Now, you may actually see and feel pulsation, okay, and that'll be like a bruit type sound over the mass, and so you'll have to auscultate for that sound, but don't palpate it because you'll make it worse if it's about to blow. All right. Now, because of the fact that these people may lose a lot of volume because if the aorta ruptures, they're at risk for hypovolemic shock, okay? So assess them for hypotension, diaphoresis, okay, altered loss of consciousness due to impaired blood flow, as well as a loss of pulse, which occurs with blood flow, as we mentioned in previous slides. And because this lack of blood flow is going to have an effect on the heart, also you're going to need to monitor them for dysrhythmias. And that abdominal distension is key to see if that abdominal aortic aneurysm is rupturing or has ruptured. So if it's not abdominal aortic aneurysm, if it's thoracic aortic aneurysm, okay, you want to assess them once again for back pain, but now it's in your chest area, right? So you're going to assess them also for difficulty breathing, shortness of breath, difficulty of swallowing, as well as hoarseness of their voice, okay? Let's talk about some inflammatory diseases of the heart, okay? Remember, all these are like your itis, like pericarditis, things like that, endocarditis, myocarditis. Inflammation of the heart can involve different layers of the heart, and normally it's going to come after a infection of the heart, right? So infection leads to inflammation, so it's secondary to infection. Assess them for any previous history of upper respiratory tract infections, and that's going to be what you do as a nurse. So let's talk about pericarditis. Pericarditis, it could be acute or chronic inflammation of the pericardium, so pericarditis. Itis as an inflammation of the pericardium. Pain is worse in the supine position, and it's relieved while leaning forward, okay? Worse while supine, but alleviated while leaning forward. Myocarditis, inflammation of your myocardium. This also can be acute or chronic, okay? But this is going to be a result of pericarditis, systemic infection, or it could be an allergic response. Now, pain, once again, is relieved by sitting up and leaning forward, okay? Complications with this, though, could include a thrombus, eventual heart failure, and cardiomyopathy, okay? So pericarditis, myocarditis, and now it's time for endocarditis. This is inflammation of the inner lining of the heart and valves, okay? Now, for this, you're going to have to assess for these splinter hemorrhages, these small little splinter hemorrhages, okay, in the nail beds, and also check for Osler nose, okay? Remember, there's Janeway lesions in Osler nose. Janeway, the pain went away, no pain. Osler with an O, ouch, they're painful, okay? These are reddish, tender lesions. These Osler nose, right? They're painful. And they're on the pads of the fingers. It can be on hands and toes. And remember, for Janeway lesions, these are non-tender, non-painful, okay? And these are hemorrhagic lesions also, but these are normally on the fingers, toes, nose, or earlobes, okay? So these little hemorrhages, painful or non-painful. Painful, Osler, non-painful, Janeway. Janeway, the pain went away. Signs and symptoms of this, you're going to hear this pericardial friction rub, okay? And because there's this build of this inflammation, so you're going to hear like a little rub, okay, in that pericardium. You'll hear that little friction rub. You can have elevated enzymes, okay? You can have a fever as well as positive blood cultures as far as like infection go, right? Because a lot of this is secondary to infection. And you'll see like rheumatic fever being a cause of some of these endocarditis and things of that nature. Nursing interventions for inflammatory diseases of the heart. Well, you want to relieve that pressure, relieve that stress. You're going to tell your patient to be in bed as much as possible so that heart isn't going to have that rub, isn't going to be pushing against these inflamed processes. Manage the pain as much as you can so you can manage their pain, okay, decrease their cardiac workload, and increase their comfort. These are all things that should make sense to you by now, as we've discussed this several times. Always with the heart, what do? Got to give oxygen. You're going to supplement oxygen. Continue to monitor the cardiac activity, because tissue damage to the heart can lead to arrhythmias. Remember, tissue damage occurs with ischemia, lack of oxygenation, lack of perfusion. Treat them with antibiotics as you wait for these cultures, because, like I said, a lot of these come after infections, right? Sialisates, like aspirin, is usually the drug of choice because of its four-part function, right? It's anti-pain, anti-fever, anti-platelet, and anti-inflammatory. So it does four things. So aspirin is good for somebody who has this. Steroids are given because it's a more potent anti-inflammatory, so you can reduce that itis, right? You can reduce that swelling. But you really need to let them know what endocarditis is and really educate the patient, okay? That's going to be your best thing, because they're probably going to be on IV antibiotics at home. You're going to definitely have them, and you're going to document their temperature, and they need to monitor that daily for up to 6 weeks and report fever immediately. That can be a bad sign. Avoid floss and oral irrigation devices, and use a soft toothbrush, okay? Use a soft toothbrush. A lot of these carditis-like things can come with infections that get into your body via the oral route, okay? Inform all healthcare providers of a history of endocarditis and receive antibiotics before every invasive procedure. As a matter of fact, lots of dentists now will give you prophylactic antibiotics if they believe you're at risk for something like this, because, like I said, oral transmission is one of the main routes. Observe for signs and symptoms, and also for heart failure, okay, signs and symptoms of heart failure, sorry, as well as for embolic like phenomena. So if you suspect an embolus, or you see embolus-related phenomena, right? We talked about how PEs come across. That's an embolus, or fat embolus, right? All right, let's talk now about cardiac tamponade. What is cardiac tamponade? Cardiac tamponade involves accumulation of fluid in the pericardial sac, okay? So what that happens is when you have fluid in the pericardial sac, okay, it restricts ventricular filling because it can't expand the way it would like it would normally, so you prevent filling of the ventricle. And as a result of less blood going into the ventricle, guess what happens to cardiac output? It goes down, it goes down. So how are you going to know if it's cardiac tamponade? Well, it's characterized by these distant muffled sounds. You can have distended neck veins, right, because it's not allowing ventricular filling, so it's backing up. You have distended neck veins, right, as well as as well as diminished or absent pulse, and this is your Beck's triad, okay? Signs and symptoms of this is your pulsus paradoxus, okay? This is the difference in pulses between the extremities. Increased CVP and jugular venous distension. We are talking about distended neck veins, but it's JVD with clear lungs, okay? JVD with clear lungs on this one. And we already mentioned the distant and muffled sounds, as well as decreased cardiac output as a direct result of this inflammation of the pericardial sac, preventing filling of that ventricle, right? So the ventricle doesn't fill up and cardiac output therefore is decreased. What's normal cardiac output? 4 to 8 liters a minute. How do you calculate cardiac output? Stroke volume times heart rate. So, nursing intervention for somebody that has cardiac tamponade, okay? You're going to have to place the patient on a cardiac monitor, right? See how severe this is and make sure you're monitoring them for arrhythmias. Prepare the patient for a chest x-ray and maybe even an echo, okay? As well as prepare the patient for pericardiocentesis. So what they'll do is they'll remove that fluid by inserting a needle and pulling it out and withdraw the fluid that way, okay, via a needle. So let's talk about valvular heart disease, right? Diseases of the valves of the heart. So there's two types. You have a stenosis or regurgitation. So stenosis is when the heart valve can't fully open, right? It can't fully open. It's stenosed, okay? If it doesn't close all the way, that's called regurgitation, right? Because think about it this way. Blood's going this way, right? Going this way. So once the blood goes, the valve needs to close. So the blood can't backflow, right? So blood's coming in, valve closes. Blood's coming out, valve closes. Blood comes out, valve closes. If it doesn't close all the way, right, that blood that came out because it's high pressure, pushed out, right, can come right back in, and that's called regurg. So that's how you remember the regurg is when it doesn't close, stenosis is when it doesn't open, right? So you can have, with stenosed valves, you'll hear these opening snaps, right? Mitral stenosis. Well, this is when the leaflets of your valves become stiff. And so this means that if it's stiff, right, you're going to prevent normal blood flow. Well, where is the mitral valve located? It's on the left side of the heart. I always remember, leave me alone. LMA, okay? Leave me alone. LMA, left side, mitral valve, aortic valve, left side, all right? So mitral valve is between your left atrium and your left ventricle. So here's a mitral valve. Okay, let's do it this way. Left atrium, left ventricle, trying to go down, right? All right, it goes down that way. But if it doesn't, if it's stenosed, then you're going to have an impediment to flow. Okay. Now, mitral insufficiency or regurgitation occurs when that valve can't close fully. So as the blood gets pushed through that valve and that ventricle contracts, right? So that ventricle's going to contract, and as it contracts with all that force to push blood out, some of that blood's going to rush back up to the mitral valve because that valve failed to close and it's still open. So there's a pathway there for that blood to go back up. Mitral valve prolapse. Mitral valve prolapse. This is actually pretty common. Okay, mitral valve prolapse is when that valve leaflet goes into the left atrium during systole. And with mitral valve prolapse, you hear like this mid-systolic click they tell you. So one side note for you, mitral valve prolapse happens a lot in people with connective tissue disorders like Marfan syndrome. And what's that? That's a defect in fibrillin, right? The people with Marfan, they have these long arms, kind of like mine, okay? And so the joke is, you never want to get into a slap fight with somebody who got Marfan because you could be standing all the way over there and all of a sudden, pop, comes out of nowhere. As far as aortic stenosis goes, that's going to be narrowing of the aorta, right? Because it's not, that's what stenosis is, right? A stenosed artery or a stenosed valve in this case. And because it's stenosed, now what's happening is it's obstructing flow outside the left ventricle, right? So from the left ventricle to the aorta, this aortic valve, when stenosed, is not allowing adequate blood flow through that ventricle. That's the opposite of aortic insufficiency. That's just like mitral regurg. This is aortic regurg. And what aortic regurg does is when that ventricle contracts, the aortic valve hasn't closed all the way, and blood can once again come back through and regurg. Rheumatic heart disease, we mentioned earlier, okay, is linked here to the development of mitral valve stenosis, mitral valve regurg, as well as aortic valve regurgitation. So this is rheumatic heart disease. Raynaud's disease is a vasospasm of the arteries, and it's more common amongst females, okay? And it's more common in the upper digits of the upper extremities. Upper digits of upper extremities. We're talking peripheral, right? So upper digits of the upper extremities. What triggers it? Well, it's going to be triggered by stress or exposure to cold or smoking. Why is that? Because it's hard to get blood flow to peripheral parts of your body anyway, right? So if you vasoconstrict when you become cold or by smoking, right, you'll make it even harder for that blood to get there, and it's more common in females. So what's going to happen when you have restricted blood flow to your fingers and toes, like we talked about earlier? That claudication, right? The intermittent claudication, that pain in your fingers or a burning sensation in your fingers. So this vasospasm continues. Blood supply gets compromised, right? And you can eventually have cyanosis and gangrene or necrosis. And Raynaud's phenomenon is like the American flag, red, white, and blue sometimes, right? Get that blue coloration, that discoloration. How are you going to manage somebody with a PAD? Well, you're going to tell them to avoid their predisposing factors. Avoid exposure to the cold. Wear warm clothes. Manage their pain and help them with their emotional stress, okay? As well as we can give them peripheral vasodilators to help increase blood flow to those areas. So there's a disease, this Bourget disease, BU. I always say BU is for the Jew because it's more common in Jewish people of Jewish descent. BU is caused by smoking. A lot of it is due to smoking, right? So another word for this is thromboangiitis obliterans. So BU, for the Jew, the severe smoking Jew, okay, it happens in Jewish people, it's more prevalent in them, is due to smoking. Now, don't get caught up with the smoking. It's not really the smoking, it's the nicotine. So if they're injecting the nicotine, if they're chewing the nicotine, if they're smoking the nicotine, they're going to have enough vasoconstriction to compromise blood flow to the peripherals. We call that thromboangiitis obliterans. Now, this is inflammation. This is an autoimmune type disease. It's inflammation of your small and medium arteries. Okay, but this time it's common amongst the arteries of your lower extremities. And it's, like I said, it's usually triggered by smoking and more common in men. Main cause of this can be genetic or hereditary, okay, as well as it could be immunologic or like a coagulation abnormality, which is impeding blood flow. Once again, what happens, guys, when you have impaired blood flow to certain extremities and distal areas? Intermittent claudication. So this will be claudication of your jaw, your extremities, okay? And this will be pain on exertion or walking that is relieved by rest. You'll have weak pedal pulses, right, because it affects the lower extremities, as well as pallor because you don't have the red blood flow coming, so it's going to look pale. And because you have a lack of blood flow, you'll have decreased sensation, like this pins and needles feeling. So, it's caused by smoking. What are you going to tell them to do as a nurse? What's the best medication? No medications. You're not going to tell them to go take Chantix or use a nicotine patch. That's not going to work. First thing, tell them to stop smoking. Okay? Then give them antiplatelet drugs to prevent clotting, as well as DVTs. And then you can do a sympathectomy, which is going to alleviate their pain. If this gets severe enough, if that blood flow gets bad enough and it becomes necrosis and gangrene results, you may have to do amputation on this, okay? So if they're amputated, we already went through the emotional support, and they might have phantom pain, and we can use that mirror technique if you don't want to use medication for that. Let's talk about some venous thrombosis. Venous thrombosis, well, what's the risk factor for having a thrombus in your vein, right? So this is going to be something such as a varicose vein could lead to it, right? Heart failure could lead to it. Immobility could lead to it, right? Remember, thrombus in general can be caused by sedentary lifestyle or lack of movement in general. So a thrombus is a blood clot, right, that has traveled. Let's think about it simply. So what else would cause it? Well, hypercoagulability, when you're increased risk of clotting, okay? And remember to keep in mind, estrogen causes an increased production of these clotting factors, okay? So that can also be a risk factor for venous thrombosis. Thrombosis can also result from injury to the venous wall from like IV injections. And post-op or following surgery, especially when you have orthopedic or abdominal surgeries, because you end up being more stationary then, right? Pregnancy or use of contraceptives, as we mentioned earlier, as well as an inflammatory bowel disease called ulcerative colitis. What are the types of different thrombus? Well, we have thrombophlebitis, which means with inflammation. We have phlebothrombus, which is without inflammation. Phlebitis is a vein inflammation that's associated with invasive procedures such as IV use. Then we'll have the DVT, which is deep vein thrombophlebitis, which is more serious and has a high risk of pulmonary embolism. And if you remember, we went back to talking about airplanes and how they want you to do exercises to prevent orthostatic hypotension, and stationary lifestyle can lead to DVT and eventually PE and even cause death. So we talked about how venous thrombosis, especially DVT, can be caused by, things that relax the blood vessels down there and lead to orthostatic hypotension. So let's talk about some peripheral vasodilators real quick that can cause that hypotension. So these vasodilators act on smooth muscle layers of the blood vessel, and they block the alpha adrenergic nerves, and they stimulate beta adrenergic nerves. Don't get hung up on those details too much. These direct-acting vasodilators are like diazoxide, minoxidil. Minoxidil is also in Rogaine, right? Nitroglycerin, which we've already talked about, and sodium nitroprusside. Sodium nitroprusside is the only drug in America that has cyanide in it. So be careful for cyanide poisoning. And sodium nitroprusside is actually the drug of choice most of the time in the ER for really reducing hypertension quickly. Peripheral vasodilators are used to treat peripheral vascular diseases, right, which we talked about earlier. Peripheral vasodilators are used for peripheral vascular disease as well as symptoms associated with cerebral vascular insufficiencies. And we mentioned both of those earlier, right? Also used to treat Raynaud's phenomenon, which we mentioned earlier, right? Because there's not enough blood flow going to the fingertips, right? So we just vasodilate. Side effects of having too much blood flow in the peripheral area may mean that there's not enough blood going elsewhere, so you can have lightheadedness and dizziness as a result. We talked about orthostatic hypotension several times, okay, and how that results in flushing because of vasodilation, and also how that leads to a reflex tachycardia. Common meds that are used as peripheral vasodilators are your alpha blockers, calcium channel blockers, okay, your alpha blockers and your calcium channel blockers. Well, in addition to peripheral vasodilators, we also have peripheral vasoconstrictors. So what is that going to do? Well, you're going to vasoconstrict now, and this can lead to tachycardia also, as well as hypertension, because now you're tightening too much and raising blood pressure. It can also lead to headache, GI autonomic dysfunction, specifically constipation in this case, okay? Now, you give this concomitantly with cardiac stimulants for shock and cardiac arrest. It can cause vasoconstriction in the peripheral arteries, which is the goal, but as a result, it'll shunt blood to central organs of the body during shock, so that's why we use it then. What are you going to do if you're a nurse? Well, you're going to check the vital signs. Make sure your IV lines are patent, right, because these medications will probably go through IV lines. Always do a CBC. CBC always comes up. Let's talk about a complete blood count. CBC is a red blood count. It's a complete blood count. And red blood cell count can decrease in rheumatic heart disease and infective endocarditis. It can also increase, though, in inadequate tissue oxygenation. And let's talk about white blood cells. Well, white blood cells are important with your immune system. So they increase in infections and inflammatory heart diseases, as well as myocardial infarct. And the reason they do that is so that white blood cell can go and get rid of this necrotic tissue. Okay, so if you have an infection or necrotic tissue, you can have increased white blood cells. And with infections, increased WBC white blood cells is a sign that your immune system is trying to combat an infection. You can get an elevated hematocrit. That's just like increased concentration, let's say, of your blood because you've depleted your vascular system. And decreases in hemoglobin and hematocrit can be indicative of anemia. In addition to CBCs, you're also going to check serum lipids. And so these lipids are your cholesterols, your triglycerides, and your lipoprotein levels. And this is going to show you and be able to gauge a risk for coronary artery disease. So keep in mind that normal cholesterol range is going to be lower than 200 milligrams per deciliter. Remember, LDL range is 130, HDL range is 30 to 70. LDL is about 130, HDL is about 30 to 70. Lipoprotein will increase the risk of you developing atherosclerotic plaques as well as increasing clot formation. And normal value for these lipoproteins is going to be around 30 milligrams per deciliter. Additional diagnostic tests that you may conduct or may be asked to conduct will be taking a look at homocysteine levels, because homocysteine levels will be indicative of an increased risk of cardiovascular disease. And these homocysteine levels should normally be less than about 14. C-reactive protein is something that will detect inflammatory response, okay? And it can, kind of like ESR does, CRP also does that. And so if you have an elevated ESR, that means you have an inflammatory process, maybe like a development of atherosthrombus. A low risk is when you have a CRP of less than 1. If it's above 3, you have a higher risk, okay? Microalbuminuria is, albumin is a protein and micro means small, so microalbuminuria means small protein in the urine or little bits of protein in the urine. It can be indicative of dysfunction in cardiovascular disease. Before we get into talking about the EKG, please make sure you have a solid understanding of the electrolytes as we discussed in the nursing sciences lecture. Let's talk briefly about your BUN, blood glucose, and BNP, and we'll relate this to how the heart works before we get into some more imaging things such as chest x-rays and EKGs. Blood urea nitrogen will elevate, these levels will be elevated in heart disorders as they relate to causing impediments to renal circulation. So heart failure will cause impediment to renal circulation. Cardiogenic shock will cause impediment to renal circulation. So as a result of that, BUN may go up. Blood glucose, an acute cardiac event may cause a rise in blood glucose. And let's talk about BNP and ANP. BNP is B-type natriuretic peptide, which is released in the atrial and ventricular areas due to stretch, and that marks CHF, right? So it's released due to stretch, and so you will see BNP levels rise when stretch or stress on that ventricle and atria is increased. Normal levels of BNP is about 100, and higher the level is, that means the worse the CHF is. Keep in mind, we also talked about ANP, which is released by the atria due to increased stretch in the atrium, and that can cause natural diuresis and make you pee more, and that's actually what can cause a physiological diuresis when you have SIADH, symptom of an inappropriate ADH secretion. Simple image study before we go into the EKG is your basic chest x-ray. These are anatomical changes can be seen in a chest x-ray, as you know, and it's done as an initial image exam to determine the size, silhouette, and portion of the heart. You want to prepare your patient for this radiography by removing the jewelry, as we discussed before, and letting them know why we're doing it, and make sure that the patient isn't pregnant, and take precautions to avoid radiation to yourself by wearing protective gear such as lead. EKGs record the electrical activity of the heart, and they're good for detecting arrhythmias, right? Dysrhythmias, as well as to see how effective medications are and where an MI is and how bad an MI is. So make sure that the patient is lying still and reassure them that this electric shock will not occur, and document any medications that they are taking prior to an EKG. And I know we've talked about these already before with these other things. I just want to recap them now as we're talking about these imaging studies. Holter monitoring. Holter monitoring is when a patient wears a Holter monitoring device, And this way, ECG or EKG activity is monitored and recorded for 24-hour periods of time. So you can really ascertain what's happening and what's causing these cardiac abnormalities. This will help you determine the type of dysrhythmia they're having, as well as any interactions with pacemakers. Ensure that the patient resumes normal activity. You don't want them to be getting monitored while they're changing their lifestyle, because that's not going to give you an adequate representation of their activity. So an echocardiography, this is a ultrasound that evaluates the structure and function changes in the heart. So it'll look at chamber size, your ejection fraction, your flow gradient across the valves. What you want to do as a nurse prior to this exam is make sure that they know this is a completely painless procedure. It might be a little uncomfortable, but it's painless. Okay. Sometimes the jelly they use makes people tickle a little bit or something, but it's not bad. It can take up to 30 to 60 minutes. And the patient needs to remain still during this exam so you can get clear pictures. TEE is a transesophageal echocardiography, and this allows electrical ultrasound imaging of the cardiac structure and the great vessels via the esophagus, so you can really check for clots with this. Nursing interventions before somebody undergoes a TEE procedure is definitely to find if they've ever had any esophageal surgery before you stick something down there, if they have any malignancies or allergies to anesthetics. You're going to have to numb that throat. Place the patient on NPO, strict NPO for 4 to 6 hours before this exam, and void prior, remove their dentures. Makes sense, right? Because if you are sticking something down their mouth, that denture may become dislodged. So you're going to have to administer a sedative to them and continuous cardiac monitoring. And because you're sticking something down the throat, you don't want them to have a gag reflex. You're going to give them something to kind of just numb that area so you can suppress that gag reflex. You're going to need to position your patient in a chin to chest position, and what that'll do is that'll allow that endoscope to pass in a little easily, right? After they undergo a TEE, what are you going to do? Well, you still want to suppress that gag reflex, and you still want to keep them NPO. And now you want to put them in a lateral or semi-Fowler's position because you don't want them to aspirate. And if you don't put them in those positions, they'll be at risk of aspirating, right? You're also going to want to make sure you promote lung expansion. So you'll ask them to cough and take deep breaths to expand their lungs. You might have to give them throat lozenges, right? Because they're going to have dry throat and dry mouth. So give them something to kind of lubricate their throat and mouth again. Observe them for complications also, such as esophageal bleeding because you have stuck something down there, pharyngeal bleeding, right? Same principle there. As well as for cardiac dysrhythmias and their vasovasal reaction to that device being in their throat. And they might, as a result, have transient hypoxemia, so check that pulse ox regularly after the TEE. Let's talk about some other electrophysiological studies. So we have this programmed, what this will do is it's kind of like a programmed electrical stimulation of the heart. And they do this to induce a dysrhythmia. Now, why would you ever want to give somebody an arrhythmia? To make sure you're accurately diagnosing them, because you don't want to give them the wrong medications. You want to figure out exactly what's going on so you can have a more specific and targeted treatment. You also have EBCT, and all this stands for is Electronic Beam Computer Tomography Scan, EBCT, Electronic Beam Computer Tomography Scan. And this will determine whether there are calcifications, if they have calcifications in their arteries, and they kind of score these coronary artery calcium. So they have a coronary artery calcium score, and normal score is going to be below 400. Okay, so above 400 is an abnormal score. We talked briefly earlier about cardiac cath, right? To assess and gauge blockages in the heart. So this is called an angiography or cardiac catheterization. It's done in the cath lab by usually an interventional cardiologist. It is going to visualize the patency of the airway to see if it's open. Sorry, not the airway, the artery, to detect any strictures, narrowing, or thrombus formation. So before they undergo this procedure, you're going to make sure they're not allergic to dyes, because you're going to use a dye to kind of light up the vessels, let's say. And it's usually iodine-based, so make sure they're not allergic to iodine or shellfish. They're going to need to be in bed rest because you're going to go through the femoral artery, and they're going to need to really, for the next 6 to 8 hours, be in bed so they don't, put any strain on their artery. So don't let them flex that groin either, right? One other thing you're going to need to do, because it is a procedure going through an artery, you're going to want to assess and check for bleeding after the procedure. Especially, so let's say if it's a right-sided angiogram, they will probably use a median or antecubital arteries. If it's left-sided, they'll probably just use a femoral artery. So you're going to check those sites for bleeding. And if you see bleeding, you can use sandbags or sand packs, ice, or direct pressure to prevent that bleeding. PCTA, percutaneous transluminal coronary angioplasty. This is, like I said, we're going into an angiogram to do it and assess it, right? But if we find a clot or an impediment to flow, they might dilate the arteries with this procedure via a balloon catheter to open the lumen of this vessel and improve arterial blood flow. So when is this indicated? This is in an evolving heart attack, MI, or alone or in combination with medications to achieve a reperfusion, to get perfusion back to areas that would have lost it or have compromised perfusion. You can have some complications as a result of this procedure, so because you're putting something in the artery, it can dissect or even rupture. You can get embolus or plaque formation, or an embolus of plaque formation, as well as spasms, and even an acute heart attack. So a lot of times you'll see people that have these put on Plavix or clopidogrel to prevent clot formation, right? Keep that blood thin in those areas so it flows through that stent without causing another complication. Before the procedure, you need to keep the patient NPO because we are going to use anesthesia to put them under, as well as make sure that informed consent is obtained, and you're going to witness that. Make sure they don't have allergy to iodine, and like we talked about with the angiography, right, the angiogram, and hold metformin because metformin can cause an allergic response when iodine is used. What are you going to do after the procedure? Well, after the procedure, what you want to do is assess their distal pulses to make sure that they're still getting blood flow down there, right? And bed rest for 6 to 8 hours, like we stated before, because they still had that procedure, the same one. Encourage them to have increase their intake of fluids to help get rid of that dye, help them excrete that dye from those kidneys. And make sure you give them the medications the doctor has ordered, whether they be anticoagulants, aspirin, or drugs like heparin or other antiplatelet agents. So central venous pressure, we've talked about this before. This is going to, how are you going to monitor CVP? Well, you're going to monitor it. You're going to monitor the pressure within the atrium of the heart. And this is going to allow you to, gauge the blood volume and the adequacy of venous return to the heart to make sure that enough blood is getting back to it. And it's going to be used in patients with CHF, burns, or people have massive fluid and electrolyte disturbances. Okay, so CHF, right? Burns, massive fluid and electrolyte disturbances. So what are you going to do as a nurse? Well, you need to make sure you zero the level of this manometer, which is placed at the right mid-axillary level in the fourth intercostal space, right around the level of the right atrium. You're going to want to make sure you keep the patients in a supine position, okay, unless the doctor has told you it's contraindicated. Readings are taken in the same position that you take the initial reading in, so you have consistency, all right? And maintain asepsis, What are your normal readings? Well, your normal readings are about 2 to 6 millimeters of mercury. Other parameters to validate your CVP readings are going to be your blood pressure. You're going to want to check their urine output and their pulse rate, okay? If their CVP is elevated, that might be a sign of overhydration or heart failure or even pulmonary artery stenosis. And that will bring us to the end of our cardiac lecture.